1, 2, 3, 1, 2, 3, haciendo pruebas por el canal de inglés. 1, 2, 3. ¿Sí? ¿Y en el de español me escuchan bien? Yo... Ok. A ti. Gracias. Javi.
Hola, Ana.
Es 1, 2, 3, 4, 5, 6, 7, 8, haciendo prueba por el canal de inglés. ¿Se escucha bien?
Sí, se escucha muy bien, Ana. Sí, por favor.
At Cooper University Center in Camden, and my talk is entitled "Avoid Running on Empty: Applying a Focused Approach to Resuscitation." And this is a talk that I modified a little bit from the Society of Critical Care Congress. This is the Asman Lateral memorial lecture that I provided.
Sí, estoy escuchando.
So I have no financial disclosures. I am, however, a member of the Surviving Sepsis Campaign Steering Committee, and also
1, 2, 3, 4, estoy en el canal de inglés. ¿Sí me escuchan? Muchas gracias, Francia. Sí, estoy en el canal de inglés. Quería yo preguntarles, ¿así es? ¿Perdón? Sí, quería preguntarles, ¿así es como se va a escuchar ya durante la transmisión de la sesión o va a entrar desde streaming, desde otra plataforma? Ok, muchas gracias. Sí, si fueras tan amable, nos pueden subir los videos. Exacto, muchas gracias. Sí, con mucho gusto. Sí, déjame ver si todavía tengo yo oportunidad de subirlo aquí. Aquí lo tengo hasta arriba. Lo escucho bien ahorita, sí. Sí, lo escuché bien. Sí, sí, por favor.
Thank you. My name is Sayona John, and I'm going to be talking about advances
¿Esa
in
lo
the
puedes subir un poco, por favor? Porque lo tengo hasta arriba mi micro y sí lo escucho todavía un poquito bajo. Ahí está un poco mejor, sí, gracias. Está mejor. Poquito más alto si pudieras. Sí, creo que está un poco mejor ahí, sí. Ujú. Sí, ahí va. Ujú. Muchas gracias. Chale. Sí, me parece muy bien. No, ese sí hay que subirlo, por favor. ¿Un poco más? No, un poco más. Porque acuérdate que vamos a hablar nosotras y entonces nos llegamos. ¿Otro poquito más? ¿Es lo más que pueda subirle? Ok. Está mejor, sí. Gracias. Ahí está, excelente. Ujú. Sí, gracias, sí. Más arriba, por favor, sí. ¿Un poquito más? Un poquito más, por favor. Ahí, excelente. Ujú. Sí, gracias. Ay, perdón, te estaba hablando, pero sí te escucho. ¿Quieres que lo interprete sobre el canal de inglés o me voy al canal de español? Sí, claro.
When we look at ARDS patients and think about what are the factors that actually drive mortality and what's modifiable, this lung-safe analysis here shows these three parameters that we set on the mechanical ventilator, respiratory rate, PEEP, and peak inspiratory pressure, are related to mortality. And you can see here that above a threshold of about 10 or 12, there's a very linear relationship between driving pressure and mortality.
Sunrise is just for you, so come along and take my hand.
Bien, muy buenas tardes. Muchas gracias por conectarse a este segundo día de nuestro 24º Foro Internacional de Medicina Crítica, el cual, bueno, el día de hoy contaremos con un nutrido y renombrado grupo de profesores, 10 para ser exactos, y todos nos hablarán sobre distintos temas, como siempre ha sido, de la medicina crítica. Y bueno, en primer lugar, procederé a presentar a todo el bloque en un inicio. En primer lugar, el doctor Phillip Dellinger, el cual una vez más nos ha hecho el honor de acompañarnos, como desde hace 25 años, 24 cursos, pero él desde antes ya venía con nosotros. Y bueno, su tema el día de hoy es sobre distribución orgánica desde la perspectiva del patógeno, ¿no? Esto, como todos sabrán, el doctor Dellinger es un profesor distinguido y académico del Corporate Medical School de la Universidad de Bowen. Es attending en cuidados críticos y el director en senior del Instituto Cooper de Salud. Y además anteriormente fue presidente y jefe de la medicina de esta institución de la Universidad de Bowen, y es profesor adjunto en el Departamento de Medicina Pulmonar de la Universidad de Texas en el MD Anderson Cancer Center. Él ha tenido una gran experiencia en el manejo principalmente de sepsis, es uno de los seniors del Surviving Sepsis, uno de los principales promotores, y bueno, nos ha ayudado con todo esto, aprender la evolución de la sepsis, el abordaje y el tema. Después del doctor Dellinger, posterior al doctor Dellinger, tenemos un grupo, otro tema, que es la experiencia en decúbito prono desde la perspectiva de enfermería. Esto a la luz del COVID y de tanto uso de decúbito prono, creo que es sumamente interesante conocer la participación de la enfermera Alejandra Rodríguez, que es una enfermera de cardiovascular, de terapia cardiovascular, intensiva cardiovascular, del Instituto Nacional de Cardiología Ignacio Chávez, la enfermera Jenny Huerta, la cual es jefa de servicio de áreas críticas del Instituto Nacional de Ciencias Médicas y Nutrición Salud Rural, y la enfermera Carolina Nava, que es licenciada en enfermería y líder clínico de la terapia intensiva de la unidad temporal COVID en Banamex. Creo que esto nos va a dar una perspectiva interesante para, sobre todo a los médicos que vemos la parte médica, pero que todo lo que está detrás lo valorarán de primera mano. Posteriormente seguirá otra profesora muy distinguida y que también ha estado apoyándome mucho, que es Christa Schorr, que tendrá dos temas, el cual el primero de ellos es evitar correr en el vacío aplicando un abordaje enfocado en laminación, y el segundo sería el Surviving Sepsis en 2071, donde vamos a aprender del pasado para informar en el futuro. Christa es una pieza medular en Cooper, donde además coordina toda la parte de investigación. Es una enfermera con formación científica clínica, es profesora asociada de medicina también en la Universidad de Cooper. Ha trabajado 5 años practicando junto a la cabecera del enfermo, y bueno, fue directora del programa para ensayos clínicos de sepsis en América del Norte, y ha recibido una cantidad de reconocimientos, dentro de los que se encuentra los que le ha dado la Universidad Thomas Jefferson, y su maestría en enfermería y doctorado en práctica de enfermería en la Universidad de Texas. Le agradecemos también que siempre haya estado con nosotros, apoyándonos aún en estas circunstancias difíciles como es en esta pandemia. Posteriormente, otro gran amigo y profesor conocido es el doctor Nicolás Gil, que habla del soporte ventilatorio no invasivo en la época de la pandemia. Como sabemos, él fue expresidente del ICCP, del ETS, perdón, y es el jefe de la universidad, de la división de medicina crítica y enfermedades del sueño en Tufts Medical School of Medicine en Boston. Y bueno, sus áreas de interés pues, han sido principalmente ventilación invasiva, hipertensión pulmonar. Después la doctora Sayona John, ella es de Rush University, nos hablará en el avance en el manejo de la hemorragia intracerebral. Ella es pertenece al departamento de ciencias neurológicas del Colegio de Rush, y está en el departamento de cuidados neurológicos. Siguiente será el doctor Scott Witters, el cual nos va a hablar de su tema, se llama No te examinar por el programa en síncope, que no puedes perder, algo que no puedes perderte. Y es profesor asociado, dean asociado en el Camp Temple del Colegio de Medicina de Texas A&M, y además es un médico cargado o asignado al departamento de emergencias en Baylor Scott & White. Por último, para cerrar el día de hoy, como dicen con broche de oro, el doctor Neil Ferguson, el cual nos hablará de qué debemos de vigilar y controlar en el paciente con ECMO, en el drive del paciente con ECMO. Él es jefe de medicina en el área de terapia intensiva en el sistema, en el network de la Universidad de Toronto. Es profesor titular de la División Interdepartamental de Medicina y Cuidados Críticos, y ha tenido nombramientos en el Departamento de Medicina y Fisiología y el Instituto de Políticas, Gestión y Evaluación de la Salud de la Universidad de Toronto. Es científico senior en el Instituto de Investigación de Toronto General, y actualmente es responsable de cuidados críticos de la red de cuidados críticos posibilidad. Con esto creo que hemos tratado de conjuntar un buen número de pláticas que esperamos todos aprovechen hasta el final. Y ya sin mayor espera, pues ya lo tenemos aquí esperando, agradecerle otra vez al doctor Phillip Dellinger y nos conectamos para dejarlo hablar.
Ready, doctor.
Hola, buenas noches.
¿Qué tal? Buenas.
It is indeed back in Mexico again, unfortunately only virtually, but virtually is better than not at all. I certainly have many friends and colleagues and have interacted with the attendees of this course over many years, and this course, the faculty and the attendees are near and dear to my heart. My topic, organ dysfunction in sepsis, the pathogen perspective, is related to how we think of what the pathogen does in sepsis. And I'm going to talk a little about some very specific pathogen-related features that may not cross our mind as we deal with sepsis-induced organ dysfunction at the bedside. The adaptive immune response system is the body's immune system, how it deals with infection, how it recognizes microorganisms, and how it triggers the immune system to kill and to clear the organism from the body by recognizing specific antigens on the microorganism, whether it be bacteria, fungus, or virus. There is some overlap on these pattern-associated molecular pattern molecules on the organism. These PAMPs are recognized by our body's immune system, typically by various body T cells and monocytes that recognize these pathogens and trigger the immune system. Pattern recognition receptors on host immune cells identify these pattern-associated molecular pattern molecules on organisms and generate various immune responses intended to clear the organism. Sepsis is defined as a dysregulated host response to infection leading to organ dysfunction. We typically think of the pathogen as a trigger for this dysregulated host response, where organ dysfunction is driven most prominently by an overly zealous or overly exuberant pro-inflammatory response, inducing cellular injury away from the infection, systemically in the body. The immune response is supposed to clear the infection at the infection site, but when it gets into the systemic circulation, it induces injury in organs distant to the infection. We now recognize that following the initial pro-inflammatory response, there is an anti-inflammatory response to that pro-inflammatory response, which in certain patient groups may well be the primary driver for organ dysfunction. But what I'm going to do in the ensuing 20 minutes is to talk about some very specific pathogen related issues that are important. The impact of the pathogen, I'm going to talk about what's called superantigens generated by the pathogen. I'm going to talk about a new concept having to deal with toxin load and irreversible shock. I'm going to present some data on persistent bacteremia and source control and how that may be a very important factor in determining outcome. And I'm going to close with talking about some recent publications of COVID-19 that have implications for the importance of the pathogen as opposed to the host response. So let's begin by talking about superantigens. When bacteria or other microorganisms invade the body, the body's immune system has what's called antigen presenting cells. These antigen presenting cells process these PAMPs, these antigens on the microorganisms with a very sophisticated control system that then presents these antigens of the bacteria to the T cell receptors on T cells, the CD4 cells, and this normal antigen processing is very tightly controlled. So only a small percentage of T cells are activated. However, that changes with superantigens. And superantigens, which are present on some organisms, mostly studied in bacteria, and I'll show you some examples of these, bypass the antigen presenting cells and attach directly to the T cell receptor and the major histocompatibility complex, making it a very unspecific and no longer control response. These superantigens may activate up to 20% of T cells as opposed to the normal less than 0.5%, leading to very high levels of inflammatory mediators such as tumor necrosis factor, interleukin-2, and interferon gamma. As I mentioned, these have been identified on Staph aureus and Strep pyogenes, and may be the reason why some SARS-CoV-2 infections produce the somewhat controversial cytokine storm. So let's move now to the second topic and talk about toxin load and irreversible shock. Charles Wiggers in 1950 in a book called Physiology of Shock talked about irreversible shock, meaning that there is a certain time period where you have the capability to treat, resuscitate, handle the inciting cause, and pull the patient out of shock. But there also is a line that can be crossed where you no longer have the capability to turn that shock process around. Anand Kumar has published an alternative paradigm for sepsis and septic shock, and we'll talk about that. And this is called the composite model, which makes a lot of sense. This model will come down here at the beginning of the infection. You can see that as bacteria proliferate, the microbial load grows and it gets greater and greater. And the toxins that are generated by that microbial load grow and grow as the inflammatory response becomes more and more magnified, resulting in increasing cellular dysfunction and tissue injury. A certain amount of toxin produces a certain crosses a threshold of inflammatory response called the shock threshold. And if that inflammatory response continues to increase unabated, the cellular dysfunction and tissue injury progresses to an irreversible state and death ensues. This is data that supports this theory. These data look at a cohort of patients that have meningococcal, systemic meningococcal disease or distinct meningitis or meningococcemia. And what you see here is that as the Neisseria meningococcal disease progresses, you measure Neisseria DNA in the blood, and as you progress from meningitis to systemic meningococcal disease to septicemia to fulminant septicemia, the Neisserial DNA reflecting the microbial load increases, as does the amount of LPS toxin that can be measured in the blood. And this is obviously associated with increasing mortality. The higher the toxin burden, the higher the bacterial burden, the worse the outcome. How does this bear on therapy? Here you can see that when antimicrobial therapy is initiated, there's a lag, but after a delay, you begin to see the bacterial or microbial load goes down, the toxin burden goes down, the inflammatory response decreases, and cellular dysfunction and tissue injury decreases. If you take that baseline example and look at what the effect of earlier antimicrobial therapy might be, it will dampen or diminish this curve. So you still have a lag, but now the toxic burden doesn't reach the same height, the inflammatory response doesn't reach the same height, and the cellular dysfunction and tissue injury also does not reach the same height, and therefore you get back across the shock threshold in a good direction. And I want you to notice that as you start seeing a beneficial effect here, look at the slope of the decreased microbial load, the decreased toxic burden, the decreased inflammatory response, and the decreased tissue injury. Now let's look at what might happen if you use more potent antimicrobial therapy, a therapy that penetrates the tissues better. Here you see that there's a more rapid reversal of microbial load, toxin burden, inflammatory response, and cellular dysfunction. So the implications here are the importance of early antimicrobial therapy and more potent antimicrobial therapy, maybe more appropriate dosing, better penetration into the tissues. So now let's move and talk about another pathogen-related issue, persistent bacteremia and source control. two separate issues, but tied together as far as implication. There's a lot of literature about persistent bacteremia and how it produces worse prognosis and worse clinical outcomes. A lot of this data is published with persistent Staph aureus bacteremia. These first two manuscripts that I've shown at the top of this slide are studies that show that persistent Staph aureus bacteremia is associated with worse outcome. And this third one looks at persistent bacteremia across a wide variety of organisms in the absence of a defined intravascular focus. So clinical significance and risk factors. And here is this data, which looked at 299 episodes of bacteremia, showing that short-term bacteremia mortality was 35%. In other words, if you culture bacteria, you start antibiotics and the bacteremia goes away, 35% mortality. But if the bacteremia persists despite antibiotic therapy in the absence of a defined intravascular focus, so this eliminates patients that have infected heart valve, for example. The mortality rises to 50%. Here you can see in this patient population that septic shock is an independent variable for being associated with persistent bacteremia, as is, to be associated with worse outcome. So septic shock is a profound influencer of worse outcome, as is inappropriate empirical antibiotics. But here, persistent bacteremia, you can see, has a 1.7 odd ratio. So persistent bacteremia, not good. And here's another multivariable adjusted analysis of what is associated with persistent bacteremia. And here you can see that burns and salmonella, central venous catheters, cirrhosis, polymicrobial infection, and not surprisingly, inappropriate empiric antibiotic therapy. This is an autopsy study. These are 235 surgical intensive care unit patients that died in the ICU and had autopsy. And there was a rather shocking 63 of these 71 patients were judged to have a continuous sepsis focus that had not been cleared with antibiotic therapy and source control. And these continuous sepsis foci included pneumonia, peritonitis, tracheobronchitis, uterine ovarian necrosis, intra-abdominal abscess, and pyelonephritis, pointing to the fact that perhaps we can do a better job with our antibiotics selection, our antibiotic dosing, and our attention to source control. And finally, a few brief closing comments on COVID-19 relative to the pathogen. This is a study looked at SARS-CoV viral load and its association with increased disease severity and mortality. This supports that theory that we talked about earlier. When the higher the viral load measured in the presence of SARS-CoV-2, the more severe is the respiratory disease, the higher the inflammatory markers, and the higher the mortality, implying that early identification and hopefully earlier antiviral therapy, although our antiviral therapy is not as good as hopefully it'll be one day, will make a difference. And then finally, looking at the ability to continue to grow COVID-19 in cell culture, SARS-CoV-2 cell cultures, looking at how they would persist after the initial diagnosis and what effect that persistence would have on outcome with severe COVID-19. So these are patients with mild disease severity on the right, and you can see that a high percentage of those had viable virus. This is living virus present here in week 1. It markedly decreases in the mild group in week 2. And in mild disease, you can no longer detect live virus in this study in 3 and 4. Whereas with severe disease, it's continued to be detected in the majority of those that initially had it detected, still detectable in week 2, not a big decrease in group 3, and still very high in week 4. The implication being that the body's inability to clear the virus influences the severity of disease, and also offers opportunity in that if we can get better drugs to treat and kill the COVID-2 virus, we can improve outcome. So in summary, we have the pathogen and we have the host immune system. We tend to think of this host immune system as being dysregulated and like a rogue system that's causing all the problems in the body. But we need to think about pathogen, but even more so how these two are intertwined, the pathogen and the host immune response, somewhat inseparable in implication for the patients. Muchas gracias.
What does an antigen, how does an antigen become a super antigen? What are the characteristics, or why?
That's an excellent question. It's the capability to interact directly with the T cell and not have to go through the processing of the antigen preparation cells. So it bypasses these cells that are there to sort of filter out all this antigenic stimulus and channel a reaction to an antigen in a very controlled manner. By bypassing that, it's able to go directly to the T cell and stimulate the T cell to produce cytokines.
Thank you. The next question is, are these super antigens very specific depending on the pathogen, or do you see them more frequently with a pathogen?
Yes, so they're described, the overwhelming predominance of the literature has described and identified super antigens as the cause of toxic shock syndrome. And I was telling Dr. Dominguez earlier that this is a relatively new talk for me, and that question means that when I present that slide the next time, I need to link the super antigens to toxic shock syndrome, and Staph aureus and beta hemolytic strep are the two organisms that have been primarily implicated for toxic shock syndrome due to superantigens.
The next question, Phil. You made reference to 2013. How come we hadn't given it the importance it should? Now in COVID-19, do we see the super pathogen? Because it was there, and how come we're taking it more into consideration now?
Yeah, I think the thought, you know, as many of you are aware, if not all, the idea of a cytokine storm with COVID-19 is somewhat controversial. I think when we begin to measure pro-inflammatory mediators in some patients very sick with COVID, we saw very high levels of IL-6 and other inflammatory markers. So we thought that COVID was was a virus that really stimulated the immune system much more frequently and to a much greater degree. Now, as we begin to be later on into COVID, we compare batch data where we have, 200 patients with traditional ARDS and 200 with COVID ARDS, and we measure the cytokines, and we really don't see that there is a big difference overall. Now, that doesn't mean that there aren't some patients with COVID that may have a cytokine storm, and I think there's some people that believe in cytokine storm with COVID and some don't. It's sort of like Santa Claus. But when we were thinking, if there is a cytokine storm with COVID, some people have said, well, maybe the SARS-CoV-2 has the capability to act like a super antigen and bypass those APC cells.
There's another question. Yesterday, we heard about the use of antibiotics. Do you think that early intervention and source control and early antibiotics will help modulate these super antigens, or will it not depend so much on that?
Oh, I think it would. I mean, if you go back to that cartoon I showed you where you could see the increasing microbial burden and the increasing toxins, the super antigens would be related to the increasing toxins. So if you beat back the bacterial load or the microbial load, you'll have less toxins and you'll have less stimulation. So I think early antibiotics, if anything, might be even more important in a patient with toxic shock syndrome than it would be in a patient that has sepsis in the absence of toxic shock, because everything is sort of run amok with the stimulation of the T cells.
Thank you. And one of our old friends, steroids, will these play an important role in this? Or is it just that, we just turn to them?
Yeah, so steroids act after the inflammatory cytokines are released from the T cell. So I showed you a picture that had all these cytokines that were being released from the T cell. They go on to other effector cells. They enter into the cytoplasm and they produce a propagation or continuation of this pro-inflammation. And steroids are a way of dampening or checking that system. So steroids diminish the effect of the cytokines on propagating or promulgating or continuing the pro-inflammatory response.
Thank you very much, Phil. Surely next year, we will have the continuation of this talk, knowing how interested you are on these topics. And perhaps for July next year, we will see you in person in Mexico. So thank you very much, Dr. Dellinger.
Thank you. I'll say a little prayer that that'll be the case. And to all my Mexico friends and colleagues, have a good evening. Goodbye.
Buenas tardes. Agradezco la invitación al comité organizador. Soy Alejandra Rodríguez Avendaño. Laboro en el Instituto Nacional de Cardiología Ignacio Chávez en la terapia intensiva cardiovascular. La terapia intensiva cardiovascular del instituto funciona como una terapia de recuperación para aquellos pacientes que tienen alguna alteración cardiovascular y que requieren de una intervención quirúrgica. Sin embargo, a partir de la pandemia del 2020, el 11 de abril del 2020 hasta marzo del 2021, la terapia sufre una reconversión a terapia COVID, en donde se comienzan a atender pacientes con COVID más una patología cardiovascular o pacientes con COVID solamente. Entonces, tanto la infraestructura del área física como el profesional de enfermería sufre algunas modificaciones, por decirlo así, ya que en base al tipo de pacientes que recibimos estamos acostumbrados o estamos adaptados a un tipo de procedimientos. Es ahí cuando viene o nos enfrentamos a un nuevo reto en la colocación del paciente en posición prona. Por las patologías y el tipo de terapia, difícilmente los pacientes que ingresan a esta área se llegan a pronar, quizá el 1% de estos pacientes, pero a partir del año que hemos cursado, fue muy recurrente la posición prona. Cabe mencionar que este es un procedimiento de muy alto riesgo que requiere del trabajo en equipo, del trabajo multidisciplinario, de que la comunicación sea efectiva en todos los integrantes de este equipo para que la terapia sea exitosa. El escenario que les quiero compartir es un paciente con COVID-19 en la terapia intensiva cardiovascular en un estado crítico, en donde se ha brindado la terapia máxima convencional como es ventilación mecánica, posición prona, relajantes musculares y que cumple los criterios para ser sometido a soporte de vida extracorpórea. Este paciente que vemos en la imagen ya es un paciente con COVID más posición prona y que además debuta con una falla renal aguda que requiere la terapia de sustitución renal. Pero además, la evolución después de la colocación del ECMO no ha sido la que todos esperamos o no ha mejorado esa oxigenación. Por lo tanto, se hace un consenso, los médicos deciden nuevamente ponerlo, pero ya con esta terapia extra, y entonces es aquí en donde todos los profesionales debemos de trabajar de manera conjunta para evitar riesgos, mejorar la calidad y mejorar la supervivencia también de este paciente. Entonces, se echa a andar los protocolos que durante este año se han llevado a cabo y se reúne todo el material y equipo. Se hace énfasis en la fijación adecuada de los dispositivos invasivos, como son las cánulas, el catéter, la posición de la cánula traqueal, el inflado, el neumotaponamiento. También se verifica la sonda vesical. Si hay necesidad de hacer curaciones, también se llevan a cabo. Es decir, que el paciente se encuentre con los menores riesgos, que esas curaciones duren quizá 12, 24 horas o más mientras este paciente se encuentre en esa posición. Y aquí un papel muy importante es la enfermera perfusionista o la enfermera de terapia intensiva que está a cargo del paciente y de la máquina de circulación de ECMO, ya que se debe de verificar que las fijaciones de las cánulas estén correctamente hechas y que además se haga una referencia en cuanto a la posición anatómica y las líneas de la cánula de ECMO, por si durante el procedimiento se llegara a desplazar, que ese no es el objetivo, pero tener una referencia en base a lo que vamos a realizar. También debemos de procurar el cuidado de la piel, sobre todo en prominencias óseas. En el instituto, dentro del protocolo, utilizamos aceite de oliva, también utilizamos vaselina en prominencias óseas y en algunas ocasiones utilizamos parche hidrocoloide, sobre todo en todo el camino que siguen las líneas del ECMO. Entonces, una vez que se tiene al paciente preparado físicamente, que se reúne el material, el equipo se reúne junto a la cama del paciente y además de las 5 personas que se necesitan o que se requieren para poner a un paciente sin estos dispositivos, requerimos de uno más. Uno que esté vigilante de lo que es la consola del ECMO para vigilar flujos, vigilar presiones y pues nos dé indicación de que algo pueda estar sucediendo durante esta maniobra. También se requiere de otro profesional que debe de estar al pendiente de lo que es la máquina de terapia de sustitución renal, así como las cánulas y las líneas tengan la holgura adecuada para evitar una desconexión incidental. También dentro del equipo que participa en este cambio de posición se requiere del médico de cuidados intensivos o del cirujano. ¿Para qué? Para que lleve a cabo la vigilancia y la sujeción correcta de las cánulas, ya sea que estas se encuentren en el área femoral o en el área yugular. Y el resto del equipo se va a encargar de la movilización del paciente, que se lleva a cabo en 3 tiempos. El líder es el que se encuentra en la cabecera del paciente y es el que va a ir dando las pautas para la movilización. En esta imagen podemos observar al paciente que ya está en posición prona, que le hemos dado una alineación corporal, que los dispositivos se encuentran ya colocados y pues que no se presenta ninguna complicación durante este procedimiento, siempre tratando de mantener la integridad del paciente, evitando o minimizando todos esos riesgos y daños que se le pueden ocasionar, que son inherentes a este tipo de procedimientos, y sobre todo después de que el paciente es colocado en posición prona se debe de vigilar la condición hemodinámica, la condición respiratoria. 30 minutos después se le toma una gasometría para ver cuál fue la reacción o qué es lo que podemos modificar y si ha surgido algún efecto benéfico, sobre todo, y es el objetivo que pretendemos. Una vez que ya está colocado el paciente, pues debemos, si la condición hemodinámica y respiratoria lo permite, debemos de hacer rotación de la cabeza cada 2 horas, también de las extremidades, estar vigilantes de las conexiones, de los dispositivos y pues mantener una comunicación con todo el equipo multidisciplinario. Y bueno, el éxito de esta terapia es el trabajo en equipo, el saber qué es lo que hace, la función que cumple cada profesional para el logro de esta terapia. Quise poner estas diapositivas porque me pareció dentro de este año de cuidados una situación que quizá poco vemos en cuanto al escenario que tuvimos, la protección que llevábamos a cabo, el que había gente de poca experiencia, pero que con base en la capacitación y al compromiso de los profesionales que llevan más tiempo en la terapia, pues el logro y el objetivo se cumplió de ese paciente regresara a su casa o se integrara nuevamente en una condición benéfica. Le agradezco su atención y pues eso es todo de mi parte. Muchas gracias.
Hola, muy buenas tardes. Agradezco la invitación al Foro Internacional de Medicina Crítica del año 2021, en especial a sus organizadores. Mi nombre es Jenny Huerta Ramírez, soy enfermera del Instituto Nacional de Ciencias Médicas y Nutrición y bueno, pues les vengo a compartir un poco de las experiencias que tuvimos en el ámbito de enfermería durante el cuidado al paciente en posición de cúbito prono. Bueno, voy a comenzar. Primero, quisiera hablarle un poco de los números que tuvimos, de lo que pasó durante esta contingencia de COVID, en donde en nuestro área hospitalaria, en donde yo laboro, tuvimos un total de tenemos una terapia intensiva y una terapia intermedia, en donde únicamente teníamos en la intensiva 14 pacientes y en la intermedia 8 pacientes. De ahí, dado el incremento tan grande que tuvimos de pacientes en estado crítico, hubo necesidad de incrementar más áreas críticas. Al incrementar estas áreas críticas, nosotros incrementaron el número de pacientes. ¿Por qué comento esto? Porque es algo que fue de vital importancia para el manejo y el apoyo de los pacientes con CIRA que tuvieron necesidad de requerir el decúbito prono. Nosotros tuvimos un total de 56 camas, la terapia intensiva, como les comentaba, de 14 camas, el área de semicríticos donde tuvimos 8 camas y el área de observaciones donde incrementaron a 20 camas. La estancia corta donde era pacientes postquirúrgicos se reconvirtió a una área de terapia intensiva con un total de 14 camas. Entonces tuvimos un total de 56 camas de área crítica. ¿En qué influye esto? ¿Qué pasa con esta situación al incrementar el número de camas? Pues que nosotros al año teníamos un total entre 15 a 20 pacientes en posición prono en el instituto y de ahí nos incrementó hasta el 300, 400%. Nosotros durante esta pandemia en el instituto atendimos tan solo de mayo del 2020 a marzo del 2021 un total de 400 pacientes, un poquito más quizás, que de los cuales no hicimos el conteo, pero es un aproximado de 400 a 500 pacientes. Y esto muchas veces sin contar las veces que se volvieron de los pacientes que pronamos, volvieron a supinar y después se volvieron a pronar. Entonces un paciente se contó hasta 5 veces en donde hubo la necesidad de volver a poner al paciente en posición de cúbito prono. Entonces, esto fue de vital importancia porque aunque el Instituto Nacional ya tenía la experiencia de conocer a los pacientes en posición prono, de darles el manejo, darles el cuidado, nosotros fuimos pioneros del decúbito prono en México, junto con el doctor Guillermo Domínguez Cherit, que fue el que trajo la maniobra junto con el doctor Paulino Leal en el año de 1993. De ahí empezamos a conocer y a utilizar el manejo diferente de los pacientes en posición prono. Tuvimos muchos pacientes, tuvimos muchas áreas de oportunidad, muchos momentos de desarrollo en donde hubo necesidad de crear y manejar nuevas alternativas para el cuidado, tanto el cuidado pulmonar, que es el objetivo de la posición prono, como el manejo hemodinámico, el manejo y prevención de las lesiones, que fue uno de nuestros talones de Aquiles. Desgraciadamente, al tener esa cantidad tan grande de pacientes, ¿en qué influye? ¿En qué es lo que pasa? Pues que no teníamos el personal suficiente con el conocimiento suficiente para este manejo de pacientes. Entonces, aquí empezamos, hubo un estudio que hizo la unidad de heridas y estomas de nuestra institución, en donde empezó a categorizar las lesiones por presión, que en este caso nosotros, ellas comentaron y hicieron el estudio en donde vimos que de lesiones de un total de 304 pacientes tuvieron grado 2, 242 pacientes tuvieron ese tipo de lesiones. ¿Qué quiere decir? Que se nos fue a un 95% de las lesiones. Grado 3 fueron 8 pacientes que se fueron a un 3%, y grado 4 tuvimos 4 pacientes que se fueron a un 2%. De todas estas lesiones, pues obviamente las más graves fueron las de grado 4. Entonces ahí cabe recalcar que el paciente tuvo las lesiones grado 4 tanto en hipocondrios como en muslos. ¿Y qué quiere decir esto? El paciente sobrevivió, el paciente se pudo ir a casa y darle el manejo a nivel pulmonar. Él logró salvarse del COVID, pero quedó con este tipo de lesiones que se les tuvo que dar manejo más integral en casa, más allá, aparte en el instituto sí tardó más días de estancia. ¿Cuáles fueron las zonas anatómicas que más se nos lesionaron? Pues aquí también les da un comparativo el cual realizó la clínica, en donde en la frente teníamos alrededor de 24 lesiones, que esto nos daba casi un 8%. En los cigomáticos nos daba mujeres, tuvimos 3 pacientes con lesiones, hombres 11 lesiones y total de 4.3%. En mandíbula fueron alrededor de 10 pacientes en mujeres, hombres fueron 40 hombres. Y esto, ¿por qué incrementa? O esto, ¿por qué es diferente? Es totalmente diferente porque tanto en los hombres hay barba, entonces eso nos creaba que hubiera más lesiones. Entonces, ¿qué hicimos? Hubo muchos cambios que ahorita se los voy a mencionar. En tórax tuvimos también lesiones, en las piernas, en la cara interior, en el mentón y en otras. Entonces, tuvimos un total del 60% a 80% de pacientes con lesiones por presión, y muchos de ellos, sobre todo los de grado 4, sobrevivieron y pudieron continuar en casa tratamiento. ¿Cuáles fueron las estrategias que el instituto implementó junto con el área de medicina crítica, el área de heridas y estomas y el departamento de educación? Nosotros estuvimos guiados por un plan estratégico en el cual hablamos del plan de reconversión de la subdirección de enfermería, en donde tuvimos una intervención educativa aproximadamente de 500 asistentes de diversas categorías. ¿Qué quiere decir esto? Que nosotros dimos esa educación tanto a médicos, enfermeras, camilleros, personal auxiliar, personal de camilleros, personal de inhaloterapia, personal de afanadores, todos tuvimos una guía para ver cómo íbamos a poner a los pacientes en decúbito prono. ¿Qué más hicimos durante este momento en donde estábamos en pandemia y teníamos excesiva cantidad de pacientes? También hicimos un video en donde hubo intervenciones en pacientes en posición de cúbito prono, donde les guiábamos cómo proteger a los pacientes y cómo girar. Tuvimos infografías y guías prácticas, las cuales las guías prácticas fueron realizadas por el personal del área de medicina crítica junto con el personal del equipo prono. Aquí nosotros manejamos la primera infografía. Esta es la que nosotros manejábamos de años anteriores. Durante la pandemia que tuvimos de influenza, esto fue como nosotros protegíamos a los pacientes. Nosotros les poníamos hidrocoloide, aunque ya tenemos indicado que el hidrocoloide no va a proteger, no va a prevenir las lesiones. A nosotros nos funcionaba bastante bien y en cuestión de costos era lo que más el instituto podía tener acceso. Entonces, durante las pandemias anteriores y durante el manejo de pacientes en posición prono que habíamos tenido en años anteriores, los pacientes no se lesionaban. Lo que más llegaban era tener grado 2 y eso era por un mal manejo en la colocación de los dispositivos. Entonces, en vista de que empezamos a tener un exceso de lesiones por presión, empezamos a hacer diferentes protocolos. Es donde sale la guía práctica de posición prono para recordar a todo ese personal de nuevo ingreso cómo hacerlo, cómo manejarlo, qué tener, qué material necesitas, en dónde se colocan los dispositivos, en dónde se colocan los parches hidrocelulares, en dónde poner y qué cuidados debemos de tener en vista de que había un virus que desconocíamos cómo era el manejo y que teníamos que tener las precauciones para cuidado de tanto del paciente como del mismo personal. De ahí surgieron diferentes alternativas y estrategias y al final creamos un equipo monitor en el posicionamiento de prono, donde hubo una colaboración multidisciplinaria de enfermería en cuidados críticos. Como les comentaba, nuestra terapia intensiva es una terapia que no puedo decir que es pequeña, pero a la cantidad de pacientes que teníamos, no teníamos el suficiente personal. Entonces, ese personal de enfermería se tuvo que implementar en las diferentes áreas, en las diferentes terapias, en donde ahí ellos fungieron como tutores, como guías de cómo dar el cuidado al paciente en estado crítico y en específico, cómo cuidar y proteger al paciente en posición prono. De aquí hubo implementación del equipo de heridas y estomas que en este momento hubo un manejo integral junto con el área de enfermería. Hubo un manejo en donde ellas implementaron y ayudaron a crear y a tratar de evitar todas las lesiones que se estaban teniendo en ese paciente, por lo cual nosotros empezamos a hacer un nuevo protocolo. En el nuevo protocolo nosotros les quitamos los parches hidrocoloides y que protegimos solo con hidrocelulares, pero no en todas las áreas, porque el manejo de los parches hidrocelulares es demasiado caro. Entonces, ¿cuáles eran los sitios donde más nos podíamos tener presión? Pues eran en rótulas. ¿Por qué? Porque colocamos ahora colchón de presión alterna, colchón de aire, colocamos vaselina, en donde eso les ayuda a proteger y lubricar la piel, y entonces ahí se ponían nuevamente los dispositivos. Como les comentaba en un inicio, en los hombres teníamos muchas lesiones en la cara por la barba, por el mal manejo, y porque nosotros manejábamos una dona muy dura, muy rígida, la cual se manejó, al final se cambió por una dona de microesferas. Entonces, esto ha sido el manejo que se ha tenido durante esta pandemia. Hemos tenido supervisión a través del aprendizaje dirigido, hemos tenido muchas implementaciones nuevas, el que los familiares se hayan comunicado con nuestros pacientes por medio de videollamadas. Entonces, pues esto es lo que les puedo comentar y les puedo aportar acerca del posicionamiento FORO y las nuevas estrategias que se llevaron a cabo. Después de que hicimos este nuevo protocolo, nuestras alternativas y nuestros pacientes mejoraron mucho y nuestro personal estuvo mucho mayor capacitado y se sintió más guiado para darle un mejor manejo a este tipo de pacientes. Agradezco la invitación y quedo a sus órdenes. Muchas gracias.
Hola, bienvenidos sean todos. Es un gusto y un honor el poder estar en este espacio con ustedes, tanto el auditorio como toda la mesa que integra de distintas personalidades. Un agradecimiento también al comité organizador que nos dio la oportunidad de estar aquí compartiendo una gran experiencia y un gran tema, que en especial es lo que vamos a abordar el día de hoy. Mi nombre es Dulce Carolina Nava Portillo y soy licenciada en enfermería, que en este momento pues vamos a representar a la unidad temporal COVID-19 de la Ciudad de México, la cual pues bien fue creada bajo la tutela económica de la ciudad del gobierno de la Ciudad de México y la iniciativa privada. Como ya comentaba la maestra Leonor en la presentación, pues se me dio la oportunidad de pertenecer al proyecto antes mencionado. Y pues bien, aunque fue un proyecto tanto creado de una forma express, pues este aspecto no limitó el alcance que tuvo en la participación sobre esta pandemia que estamos viviendo a nivel mundial y en especial pues aquí en este país que es México. Bien, pues el alcance que tuvo este proyecto presentó un gran reto, el cual al principio estaba enfocado pues en dar una atención de hospitalización temprana. Sin embargo, por la situación actual que se vivió en ese momento, pues se tornó a una visión para un proyecto que tenía la necesidad de brindar un cuidado crítico y especializado para estas personas que estaban padeciendo la enfermedad del COVID-19. Bien, pues ahora sí, sobre el tema de cuál es nuestra experiencia que tuvimos en esta institución de Citibanamex, unidad temporal COVID-19, podemos visualizarlo de esta forma. ¿Cómo iniciamos? ¿Qué aprendimos? y sobre todo una reflexión de qué debemos de mejorar. Bien, me gustaría puntualizar algo que en este caso para nuestra institución, un punto clave y de partida fue de que todo aquel personal que estaba elaborando ya en este proyecto había tomado la decisión propia de pertenecer a él. Entonces, esto nos dio la pauta de que todos los que formábamos el equipo, pues habíamos dado un paso al frente para vencer el miedo y el temor que significaba atender a personas contagiadas con COVID-19. Si bien al ejecutar o puntualizar, aterrizar sobre la práctica de prono, en la parte clínica, pues bueno, nos encontramos con bastantes factores, dentro de los principales, los extrínsecos, en los cuales debemos de notar la poca o nula experiencia del equipo al momento de ejecutar la práctica. Hablamos entonces de que casi un 85% del personal laborando en este proyecto no tenía una experiencia previa e incluso la capacitación especializada para realizar el procedimiento, ya que eran, en esencia, el personal de enfermería fue personal que ni siquiera había concluido quizás su capacitación en el servicio social y no tenía una experiencia amplia clínica ni en cuidados intensivos. Otro aspecto importante, el personal que nos apoyaba, como los camilleros, también nos enfrentamos a una problemática de donde ni siquiera, bueno, tenían amplios conocimientos ni experiencia tampoco en la movilización o mecánica corporal que se necesita para ejecutar la técnica. También hay otros factores como la solicitud de insumos que de cierta forma era compleja. Se podía observar una gran falta de comunicación efectiva, como en otros casos se da, de que las personas que gestionan los insumos de cierta forma no tomaban en cuenta al personal operativo para saber si realmente esos insumos eran eficientes y eficaces. En sí, pues bueno, todos estos factores ayudaban a que este procedimiento fuera muy complejo e incluso pues ponía en riesgo también al paciente al momento de ejecutar la práctica. El factor intrínseco en especial, que es la patología en sí pulmonar, que ya en el simple nombre lleva la complejidad de la cual estamos hablando, pues bueno, de cierta manera, pues aunada a todas las complicaciones y alteraciones que provocaban esta descompensación sistémica, pues bueno, también era la parte de que la estábamos conociendo en cierta forma empírica. Sí, realmente sabíamos por la experiencia de otros países, por la literatura, qué es lo que podíamos esperar al momento de ejecutar la práctica del prono, de la parte fisiológica y del comportamiento de la patología. Bien, al describir el escenario antes mencionado, pues no es difícil imaginar el caos que podíamos estar viviendo, tanto el personal de enfermería que en ese momento atendía, y sí, realmente era una experiencia de ver cómo sobrevenía esta marea intensa que no terminaba. Día tras día necesitábamos realizar esta técnica y bueno, de cierta forma teníamos errores y íbamos aprendiendo. Entonces, es ahí en la práctica diaria donde yo asimilo que no teníamos otra alternativa más que apostar a la capacitación del personal. De forma práctica, una capacitación exhaustiva sobre tanto la parte fisiológica como la parte práctica de la técnica que necesita. Bien, para esto, pues bueno, tuvimos que coordinarnos, que implementar varias estrategias en conjunto con todo el equipo, tanto médico, enfermeras, y sobre todo lo más importante que yo considero, la parte operativa, que es quien realmente se da cuenta y analiza de qué es lo que nosotros podemos mejorar, qué es lo que nosotros necesitamos. Bien, para esto, pues bueno, la unidad elaboró un manual de prono bajo los lineamientos de la institución. Se diseñó una hoja de registro para el seguimiento y la atención en cuanto al registro de la liberación de las zonas de presión y también el tratamiento de lubricación de la piel. Se tomó la decisión de asignar un personal de enfermería como líder clínico, donde tenía la función de proveer la capacitación y organizar los recursos humanos y técnicos de esta forma constituir un equipo de respuesta rápida y eficaz para ejecutar el procedimiento de la técnica de prono. Bueno, dentro de esta parte de proveer la capacitación, pues bueno, se tuvieron que derivar bastantes temas de los cuales se tenía que hacer la capacitación del personal operativo. Uno de los principales, pues fue la importancia de mantener la valoración de la parte fisiológica, tanto física del paciente en el momento en el que se indicaba la pronación. Desafortunadamente eran sucesos que no estaban tan programados ni tan coordinados. Entonces, en el momento actual, nosotros ya visualizamos como una organización mayor. Sin embargo, en el momento en que estábamos viviendo la pandemia, la indicación médica era pronar al paciente. Entonces, había varias cosas que no teníamos como ese tiempo para poder programar el procedimiento. Una de las principales, pues, era, por ejemplo, detener la nutrición, que la indicación ahora hablamos de 1 hora antes. Muchas veces no teníamos ese tiempo de anticipación para que el paciente estuviera listo en ese aspecto. Entonces, necesitábamos que el personal desarrollara habilidades y capacidades de poder valorar la necesidad. En este caso, si la indicación era pronar al paciente y no teníamos el tiempo establecido para detener la nutrición, lo que se hacía, bueno, era detener la alimentación inmediatamente y poner la sonda a derivación. Entonces, la capacitación incluía bastante para brindarles las herramientas que ellos pudieran tomar decisiones de cómo solucionar estos percances que teníamos con el tiempo, como todo. Bien, también se realizó el reclutamiento de los operadores para esta maniobra. ¿Por qué? Es importante que no todos creo que en la experiencia de la mayoría de los institutos, pues una de las principales problemáticas es la falta de personal para constituir un equipo. Entonces se tomaron estrategias de formar este grupo de respuesta rápida que ya estaba entrenado de cierta forma y que también era muy importante asignar un rol específico para la coordinación de las actividades. Otra de las cosas en las cuales nos enfocamos también fue en la seguridad del paciente. Asegurar los dispositivos invasivos que se encontraban en ese momento era de suma importancia. ¿Para qué? Para evitar el retiro fortuito de todas estas, tanto de la vía aérea como de la vía endovascular y cualquier otro dispositivo que estuviera con el paciente. Preparar al paciente también, visualizar todas las opciones que teníamos de movimiento y obviamente también dar ese margen de movimiento a todos los dispositivos de monitorización con los cuales contaba nuestro paciente de cuidados críticos. Sobre todo, tener previsto tanto la reinstalación o reconexión inmediata de todo este monitoreo hemodinámico, que era vital para saber si la maniobra o la técnica se había ejecutado de una forma exitosa. Tener todo el material listo y funcional era uno de los principales objetivos con las cuales nosotros necesitábamos estar listos. Bien, entonces, ahora sí que esta parte de la ejecución del prono, pues nos ayuda o nos obliga también de cierta forma a puntualizar en esa capacitación, en esa continua búsqueda de la información, ¿verdad? Tanto científica como en este caso de experiencia, porque realmente no teníamos una base donde tuviéramos esta oportunidad de poder comprobar ciertas maniobras, de que ya se hayan probado, sino que realmente fuimos creciendo, nos fuimos fortaleciendo bajo la experiencia también de otros países, de otros lugares donde ya habían pasado por este pico de la pandemia, pues realmente la situación que sobrepasaba tal vez que toda la terapia intensiva estaba llena, entonces hacía una demanda mayor también de los pacientes que necesitaban el prono. La seguridad del paciente, si bien lo dice, pues tiene una función, que es asegurar que todo el procedimiento sea exitoso. Entonces, creo que enfermería tiene un gran papel, una base teórica que necesitamos fortalecer para poder continuar en este aprendizaje sobre la técnica del prono. ¿Qué podemos, dentro de este análisis de cómo realizamos nuestra técnica de prono como enfermeras? Después de ver, obviamente, que en muchísimas de las veces que pronamos pacientes, tuvimos errores. Entonces, es algo que no se puede negar, es algo que no podemos dejar a un lado, sino que debemos de retomar para que en la próxima vez que estemos como equipo atendiendo esta necesidad de poner a un paciente en prono, sea con mayor calidad, ¿sí? Aumentar nuestra eficiencia y nuestra eficacia para realizar la técnica, y eso solamente se va a poder lograr si nosotros analizamos todos los errores independientemente de los éxitos que tuvimos durante nuestro actuar en esta pandemia. Me gustaría, para terminar, hacer una invitación tanto a todos los coordinadores y todos los jefes que se encargan de organizar al personal de enfermería, que no nos olvidemos de que ellos realmente son los que nos van a dar los puntos claves para mejorar. Si nosotros los escuchamos atentamente, tomamos en cuenta las opciones que ellos nos dan o ahora sí que toda la experiencia que ellos tienen, tanto de éxito como de errores, entonces sí podremos llegar a pulir un poco más esta técnica, que desafortunadamente, dada la situación actual, en estos días, estamos viendo que no fue cosa del pasado, que va a regresar, que la vamos a seguir viviendo y que necesitamos realmente un personal capacitado para poder realizar y ejecutar de manera adecuada la técnica de prono. Pues bueno, también hay muchísimos aspectos más que se pueden abordar sobre la técnica, que vamos a ir aprendiendo todavía en el transcurso de este tiempo que continuemos en la línea de atención, de primera atención a este tipo de pacientes. Aparte de que, pues bueno, el virus ha ido adquiriendo características cada vez diferentes, ¿no? Sin embargo, pues bueno, esa es mi invitación. El punto clave para mejorar es tomar la experiencia de los errores que hemos tenido, no pensar que esto se acabó. Debemos de tener en mente que realmente la pandemia continúa y que cada día vamos a necesitar mejorar este proceso. Sin más por el momento, pues bueno, agradezco su atención. Ya vendrá la fase de preguntas donde podremos puntualizar sobre algunas otras cosas. Muchas gracias.
Respiratory support in the COVID-19 pandemic. Go ahead, doctor. You can start. You can start.
extended surge that went through the end of April. So we had a lot of experience dealing with patients with COVID pneumonia and acute respiratory failure. Let's see here. There. These are my disclosures. And what I plan to talk about is some of the controversies surrounding non-invasive respiratory support. That's what NRS means, because these are considered aerosol generating procedures, high flow, non-invasive ventilation. And there was a tremendous amount of anxiety when COVID first hit the United States about exposure of hospital staff and workers to potentially infectious material generated by these procedures. And the guidelines reflected this. There were some guidelines that favored starting with non-invasive ventilation or high flow. There were some that were very cautious and discouraged the use. So we're going to go over some of the evidence that has accrued during the pandemic, and then talk a little bit about the lessons learned and the caveats and where we stand today. So first, what am I talking about with regard to non-invasive respiratory support? Well, we generally start patients who aren't too terribly hypoxemic on standard oxygen, nasal cannula, and I generally go up to 6 liters a minute with a nasal cannula. I don't think you get a whole lot more going up higher, so I generally will switch to a Venturi mask or a non-rebreather mask, which, although we talk about 100%, there's a lot of air entrainment with these masks, so it's hard to get the FiO2 up over 60 to 80%, even at the maximal flow rate of 15 liters a minute. Then we have high flow nasal cannula that has seen increasing traction in treating acute hypoxemic respiratory failure for patients with ARDS and pneumonia over the past approaching decade. And then we have non-invasive ventilation, and I'm talking about continuous positive airway pressure or bi-level positive airway pressure via a face mask or a helmet. And I'm illustrating the high flow on the lower left here, standard full face mask. And then on the right, an example of a type of helmet that we've used in the US. It's not the one they've used in Italy. And I want to make a few comments about the pre-pandemic status of these non-invasive respiratory support, because it was controversial even before the pandemic hit us. The ERS ATS guideline that I co-chaired with Stefano Nava and Paolo Novellini gave no recommendation for non-invasive ventilation to treat what we call de novo respiratory failure. We were talking about pneumonia, ARDS, hypoxemic respiratory failure, such as we see with COVID patients. We also gave no recommendation for use of these entities during a pandemic. There was some data that had accrued from SARS-1 and from the MERS, the Middle Eastern Respiratory Syndrome. And there was concern from the Toronto outbreak that non-invasive ventilation had actually facilitated spread of SARS, and they had discouraged the use of non-invasive ventilation during these viral pandemics. The Florali study was one of the most important ones that compared high flow nasal cannula or oxygen versus non-invasive ventilation versus standard O2. And it showed a significant reduction in the need for intubation and mortality rate in patients treated with high flow as opposed to NIV or standard O2, which were fairly close. So this shifted the balance toward starting more with high flow in patients with hypoxemic respiratory failure, although this study has not been replicated yet. And so we have to be careful about relying too much on a single study. And one other relevant study that kind of shook up the field was the study on helmet versus face mask to treat acute hypoxemic respiratory failure. This was a single study out of the University of Chicago, and it showed a drastic reduction in intubations and in mortality attributable to use of the helmet as opposed to a full face mask, and raised the issue that maybe the problem isn't the non-invasive ventilation as much as how you administer it. So this led to some guidelines that came out initially to help people manage patients with respiratory failure due to COVID. And I just list a few. There are literally many dozens of these that came out, but the Society, the Surviving Sepsis Campaign Society of Critical Care Medicine guideline came out favoring high flow nasal cannula as an initial mode to treat hypoxemic respiratory failure, and parenthetically did not consider it an aerosol generating procedure. Non-invasive ventilation, on the other hand, it said should be used only if you don't have high flow available, and also suggested that patients with COPD or cardiogenic pulmonary edema who come in with COVID, and those are the usual indications for non-invasive, of course, they could justifiably be put on non-invasive ventilation. The World Health Organization was much more cautious and suggested that these non-invasive approaches be used only in very selected patients. New York Presbyterian Hospital, dealing with the initial surge in New York in late February, early March, used very little non-invasive as a consequence of guidelines such as the WHO, and used high flow in only very selected patients and recommended against it. In Boston, at the MGH Brigham, their guidelines said not routine for either high flow non-invasive. They used very little, but at Tufts, we actually suggested its use just a mile away from the Mass General. But the anesthesiologists, many of whom had trained at the MGH, were very nervous about using high flow, and so we changed our guideline in response to them, making it an option, but we still saw quite a bit of use of it. And again, we discourage use of non-invasive, partly because of aerosol generation. Now, there's some information on the aerosol generation of these things, and some of the studies, here is a study that mirrors some of the work that David Wee has done, and the approach is to use smoke particles and then some kind of light source to light up where these particles are going. And what is being shown here on the upper right is a high flow setup with nasal prongs and just the air currents really that are generated by that. And to the upper left, this is after a standard surgical mask is placed on the same patient, and you can see that there's virtual elimination of that plume. Now, it's important to consider that this is really a study of air currents using these smoke particles, and it is not a study of spread of virus, which is really the key thing in when you're concerned about getting exposed. And this is a summary of the various devices that David Wee had looked at, and non-invasive ventilation is up at the top with the spread of particles a meter or more away, and during a cough, it may be over 2 meters, whereas high flow is down at the bottom with a relatively small area of spread. We did some work on this at Tufts, and one of the things we did was look at aerosol generation by high flow and non-invasive ventilation using a viral bacteria filter on the expiratory port of non-invasive ventilation. And this was done using healthy volunteers in a simulator room with at least 6 air exchanges per hour, which is considered the minimum for adequate ventilation in a pandemic. We used some positive controls, including a spray bottle, coughing, singing, and these generated aerosol as you would expect, but non-invasive ventilation set at 12/7 with a filter and high flow, even at 60 liters a minute, generated no aerosol over background. So this suggests that coughing and singing are greater hazards than these so-called aerosol generated procedures, and maybe our concerns were a little bit overblown, if you will. We also made an important additional step, which was to sample air from these rooms looking for virus particles in rooms that had COVID positive patients. And we used a personal sampler, which draws air about 5 liters a minute via a sampler placed very near the patient's mouth. So you get an assessment of what the individual might be inhaling at their usual ventilatory rate over a period of time. Then we used a high volume sampler, which drew in much more material from the room, much more air that's sampled. And then this scoop mask, which I'm illustrating right here, which drew the patient's exhaled gas right into a filter placed in line with the suction device at very high flow. And when you look at our results, the personal sampler and even the high volume sampler picked up very little evidence of viral particles. Both of these in asterisk were during intubations, but during standard use of high flow or non-invasive with the filter, we didn't pick up any virus at all. We did pick up virus when we used the scoop mask, which was going at much, much higher flow rates. So again, this reduces the concern about spreading virus around to our staff. Now, if we look around the globe at what people were doing using the non-invasive techniques, intubations and so forth, China, which had quite a number of early descriptions of what was going on, was using high flow and non-invasive. And this is kind of a sum and average of what was in these various reports. But somewhere 29–30% of patients at different institutions. The percent who get intubated is roughly 40%. And the death rate of these people with hypoxemic respiratory failure was astoundingly high and very concerning. The first place the virus came in the US was in Seattle. There were a couple reports out of there, and they were using very little non-invasive. They had high intubation rates, not surprisingly, and still fairly high death rates. In New York, where I showed you their guideline discouraging the use of non-invasive, they use very little, 5 and 3%, like Seattle, very high intubation rates. At the time of their publication, this was, I believe, in JAMA, there were still people in the hospital, so they could not give us an accurate mortality rate. At Tufts, where we've been keeping track of this, 41% of our starts are high flow. We used only 8% NIV, and 50% ended up getting intubation with a 25% mortality rate, which is getting closer to what's been in the more recent literature. Notably, only 1% of these patients used a helmet CPAP setup at our place, and our respiratory therapists were not fans of the helmet. It was more difficult than the other options, especially high flow, to put on. And it interfered with self-proning and so forth. Now, I'm just going to mention a few of the studies that have come out over the past year or so describing experience at different places in the world. And this first one is on patients outside of the ICU in Italy, and Stefano Nava was the senior author on this one. They pooled results at 9 Italian hospitals, and entering an ICU or getting intubated actually excluded patients. So these were patients who had hypoxemic respiratory failure, but not sick enough to end up in an ICU. 50% of these patients were treated with a helmet using CPAP, non-invasive in a quarter, and high flow in a quarter. And of course, the Italians have been looking at the helmet for years and are very experienced with it, and their staff is very familiar, and I think this explains why they use so much of it. But notably, There were no significant differences in intubation rates, in lengths of stays, or in 30-day mortalities. It was a little lower in the high flow group, but it didn't stand up to statistical significance when they matched patients. They also raised caution about infecting healthcare workers. 12% in this study all recovered well, fortunately. They concluded that these non-invasive approaches are feasible but associated with staph infection, although they could not determine where the staph was actually affected. A lot of that could have been in the community. A study on high flow out of Paris looking at an ICU population. So this is kind of the other side of the coin from the Italian study. And in 4 ICUs in Paris, they found that almost 40% of patients received high flow within the first 24 hours, very similar to what we found at Tufts. They were pretty sick patients, PF ratios in the low 100s, and after propensity matching, high flow was associated with reduced invasive mechanical ventilation at day 28 compared to patients who were not put on high flow, 55 versus 72%. There was no difference in mortality, and they concluded that high flow could help to reduce the need for intubation. Another study out of Temple in Philadelphia, Jerry Kreiner's group, looked at 454 patients admitted with COVID pneumonia, and they also were interested in high flow. That was their preferred modality, and 23% of these patients ended up using high flow. They were fairly sick patients. Average SF ratio now is 122, which corresponds to a PF ratio of about 100. Of these, 8 ended up transitioning to NIV, and 37 or 36% ended up getting intubated. So this is a relatively low intubation rate that, compared to what was reported previously. Of those who started out on high flow and got intubated, 13 or 35% died, as opposed to only 3% of those not intubated. And the overall mortality was 14%, which is really good compared to the previous publications. They looked at some predictors, including a low SF ratio, saturation to FiO2, chronic kidney disease, and a low fibrinogen. And they concluded that high flow has a place in the treatment of COVID pneumonia, may decrease intubation and maybe mortality, but they admitted that they could make no firm conclusions because they had no controls. There was one controlled study that compared the helmet to high flow, and this one looked at 109 patients out of an Italian ICU, and they found that the days free of respiratory support, which means they were entirely off everything, not intubated, not on any non-invasive devices, that was no different between the helmet and high flow. However, the intubation rate was significantly reduced with the helmet, and there were fewer invasive mechanical ventilation days with the helmet, but mortality in the end was no different. So they ended up concluding that there was no significant efficacy difference, although they said that the reduction in intubations might conserve ventilators and space in ICU for patients who really required those. One shortcoming here is that they did not have a face mask NIV control, so we can't actually conclude in this study that either of these things did anything. They worked equally well or equally poorly, but we really can't make strong conclusions about their efficacy. So what have we learned? Well, first of all, high flow, nasal cannula, and NIV probably are less of aerosol risk than previously thought. This is based on the data that I showed you from David Wee and from some of the work we've done, and others have reported similar things. High flow and non-invasive ventilation are feasible. I would agree with that conclusion that a number of these authors made, and appear to decrease the need for intubation and also conserve critical care vents in ICU space. High flow nasal cannula is often combined with non-invasive ventilation, especially during breaks, which we showed in a pre-pandemic study published just before the pandemic study using high flow during breaks from non-invasive ventilation. And we also use this combination post-extubation. The high flow seemed to be helpful in keeping secretions looser, and then the cough assist and non-invasive ventilation was helpful in getting these patients to mobilize and resting these patients who were often quite exhausted after being intubated and fighting the virus for weeks often. The helmet may decrease intubations compared with high flow, but there really is no good evidence of a mortality benefit other than in that one University of Chicago study. But it was most popular in Italy, did not catch on at Tufts, as I mentioned, or most other places in the US. There are advantages of non-invasive support. High flow, it's clearly the best tolerated of these various options, the helmet or the face mask, and it's good for a patient undergoing palliation. I mentioned the secretion hydration and help with mobilization. High flow is a better oxygenator than standard O2 because it cuts down on air entrainment using its high flow and also flushing out dead space so that your first inhaled air is fresh gas from the high flow and not what you've just exhaled. But it's not a better oxygenator than NIV, which applies a more reliable and higher pressure. High flow improves ventilatory efficiency and lowers work of breathing. This is a flow-related effect, and you will get more of this effect if you get up to 50 or 60 if they can tolerate that. But non-invasive ventilation also is effective at lowering work of breathing, mainly due to its pressure effect of assisting inhalation and counterbalancing auto-PEEP if that's present. High flow is better for self-proning. NIV and especially the helmet, it can be done, but it's more difficult for patients to tolerate. As I mentioned, we may avoid intubation and conserve the ICU ventilators. Oops. But there are some caveats to keep in mind too. First of all, we have to admit that we really don't have high quality evidence here, and we cannot prove efficacy in terms of improving mortality, improving lengths of stay, probably reduction of intubation compared to standard oxygen, I think is highly likely. High flow does generate some positive expiratory pressure, but considerably less than non-invasive ventilation, which is preferred for COPD or cardiogenic pulmonary edema, and severely hypoxemic patients, where you're more apt to get a better oxygenation response at the higher pressures. There's a risk of excessive tidal volumes with non-invasive, and this has been of great concern for patients on non-invasive approaches. There's always a risk of delayed intubation. We use non-invasive approaches to avoid intubation, but we have to watch patients very carefully because if we push too far in a patient who is on, say, 100% FiO2 and having episodes of desaturation, we run the risk of a sudden respiratory crisis leading to emergency intubation, which greatly increases the risk for mortality and other complications, and is something we very much need to avoid. So if a patient is not improving, if the patient especially is starting to deteriorate, we need to intervene right away. Also, although I did mention that our initial fear, terror sometimes about using aerosol generating procedures was perhaps a little overblown, I would still be a strong advocate for having the best personal protective equipment available when using these procedures, but also in patients who were just coughing or sneezing or speaking loudly. All of these generate more aerosol, as far as we can tell, than these aerosol generating procedures, even though our infectious control people initially during the pandemic would not give us N95 masks for patients who are coughing a lot unless they were on aerosol generating procedures. So I'm going to stop there and I will be more than happy to open up for questions. Thank you very much.
Thank you, Dr. Nicholas. Could you help me with something?
Dr. Hill, thank you so much for your excellent presentation. There are many questions from the audience that I would like to ask you. One of the most asked is, we know the use of non-invasive mechanical ventilation can cause complications. We would like to know what have been the more frequent complications of non-invasive ventilation.
Well, I think the most concerning complication is to put someone on non-invasive ventilation and not adequately monitor them. And that is what leads to people going too far in deterioration and having risk of a respiratory crisis and an emergency intubation. Otherwise, non-invasive ventilation, and here I'm talking about either CPAP or bi-level ventilation using pressure non-invasive ventilation, either with a face mask or a helmet. But with a face mask, the most common complications that we run into are mask discomfort, which is very common and is one of the main reasons why high flow tends to be better tolerated. Also, the occurrence of leaks. It's important to have a fairly tight seal with a full face mask, and either because the masks aren't strapped on properly, or the patient moves, or the patient sometimes will adjust the mask himself, we're getting leaks. And most of the modern devices that deliver non-invasive ventilation will give us a measurement of leak, an estimate. And if it's 30 liters per minute or less, I usually find that acceptable. If it's up in the 50 to 60 range, that's likely to cause enough trouble to interfere with delivery of pressure and synchrony. If it's over 60, that's unacceptable, and something needs to be done. But leaks can be a big problem. Then you have skin ulceration. With the newer masks, at least that I have access to, this has been much less of a problem than it was, say, 15 or 20 years ago. But we have to be very careful about how tight we make the straps. We want to make sure the mask isn't leaking too much, but not at the expense of an ulceration. And so one of the things that we do, one of the common areas to get an ulcer is the bridge of the nose, also on the cheeks. And sometimes there can be leakage of air into the eyes, which can cause conjunctivitis. So it's really important to try to make sure that mask is properly seated. And sometimes you can either put a little strip of silicone or a Band-Aid over the bridge of the nose to protect it from the mask. But I'm seeing that much less often than I have in the past. But those are some of the most common ones. One of the things that has created a lot of fear over the years is the risk of vomiting into a full face mask and then aspirating. And that can happen, but it's very rare. I've only seen one patient in 40 years of using various types of mask ventilation who actually ended up with a severe aspiration pneumonitis and died of that problem. I've seen quite a few people vomit into their masks, and then they cough, and you take the mask off, clean it up, put it back on, and nothing happens to the patient. You know, they have not aspirated. So you're not guaranteed to aspirate if that happens, but it is a concern, and you have to watch people closely, especially if they are having problems that might lead to vomiting, you know, gastric distension and so forth. But that's another big concern. High flow is very well tolerated. It's not as well tolerated as standard nasal prongs at low flow. You know, if you have 2 liters of oxygen through a standard nasal prong, that's more comfortable than high flow, no question. On the other hand, if you're comparing it to an NRB mask, or even more so a CPAP or BiPAP mask, especially a full face mask, then it's definitely much better tolerated on average. As I mentioned, we haven't used the helmet very much, and the one we used, I think, was lower quality than what the Italians used, but we were having some problems with leakage around the neck, getting a good seal, being able to deliver adequate pressures and having the patient tolerate it. And the higher the pressure, the more you leak. There could be some ulcerations either on the neck or underneath the axilla. You know, you have these straps that go under your into your armpits to hold the device on. So those are some of the issues, but most people seem to tolerate the helmet longer than I think they would, but it's also noisy. But anyway, that's enough on that.
Yes, of course. We have another question about what you said of, you know, it's important to monitor patients before their adverse events. So you talked about the leaks, and with that we may have to increase the tidal volume and cause pulmonary injury. So the question is there a way to assess the pulmonary injury in patients with non-invasive mechanical ventilation?
No. This is a challenge that everybody faces. With non-invasive ventilation, we do make measurements of tidal volume. The measurements on the machine are plus or minus 10% or so in the absence of significant leaks. So they're not necessarily all that accurate. But you can generally tell when patients are pulling in large tidal volumes, and sometimes they're 10 or 12 milliliters, often younger, strong people who are doing this. And there is debate that preceded the pandemic, but has continued through it, as to what to do with these patients. And some people, for example, Gattinoni, I think he gave a talk yesterday, but he came up with the idea that some people with COVID pneumonias have a relatively high compliance, low elastance, the L type, and then others who have the more typical low compliance, high elastance type. And the last I heard him talk about, he was advocating intubating the people with more compliant lungs who are taking larger tidal volumes to avoid lung injury. But we really don't have any evidence to prove that the injury is occurring or that we're preventing it by intubating patients early. So I tend to be a little less aggressive about that. Also, it's very hard to measure tidal volumes when people are on high flow, because there's so much flow and leakage. That's part of the administration. Leakage just is part of administering high flow. A lot of leakage out of the nose and sometimes mouth. So we're not very good at monitoring tidal volume in those people. So it's something that I pay attention to as to exactly when you intubate someone to lower their tidal volumes. I can't give you hard guidelines on that.
Thank you. And we have one more question about how to determine failure to the high flow nasal cannula to then decide to intubate. Right.
Well, if there are some indicators that you can make at the bedside. Obviously, someone who is becoming increasingly tachypnic, their work of breathing is increasing. They're using accessory muscles more. They're obviously laboring. They may start breathing paradoxically, tachycardic and so forth. One index that probably many people out there are familiar with is a so-called ROX index, which was described out of a European group within the last few years, actually a Spanish group. And what it consists of is the SF ratio, the O2 saturation divided by FiO2 ratio as an index of oxygenation divided by the respiratory rate. And the lower this index becomes, the worse things are. You know, if you have a very high FiO2 and a low saturation, then you're going to have a smaller numerator. And if the respiratory rate goes up, you get a bigger denominator and you get a lower value. But this combines an oxygenation index with an index of work of breathing, which, you know, in a very rough sense, respiratory rate is. And the studies have shown that this can be quite helpful in predicting. In fact, the Spanish group in a study in the Blue Journal last year showed that if your ratio is less than 4.88 at 12 hours, you better get your endotracheal tube greased up, you know, that people are likely to fail. So this is, I think, can be useful, but you always have to use clinical judgment. I certainly would not rely on one number.
Of course. Dr. Hill, thank you so much for being with us. Unfortunately, we don't have more time for questions, but we hope to see you next year in Mexico City. Okay, thank you so much.
My pleasure. Buenas noches, or buenas tardes. Yeah. Bye-bye.
Thank you so much for this opportunity to speak to you today. I'm sorry we can't be in person, but hopefully this will be informative for you. So my name is Christa Schorr, and I am a clinical nurse scientist at Cooper University Center in Kansas City. And my talk is entitled Avoid Running on Empty, Applying a Focused Approach to Resuscitation. And this is a talk that I modified a little bit from the Society of Critical Care. This is the Asman Lateral Memorial Lecture that I provided in 2021. So I have no financial disclosures. I am, however, a member of the Surviving Sepsis Campaign Steering Committee and also a member of the Surviving Sepsis Campaign Guidelines, and I'm currently the group head for long-term outcomes and goals of care. So initially, when I was preparing this talk, I really thought about, you know, the person who actually the award was named after, and it was, you know, Asman Laerdal was actually a toy maker and joined forces with two other physicians, Dr. Lind and Dr. Saffer, and created the first patient simulator known as Resusci-Annie, which most of us have learned how to do CPR using this particular device. And it was actually produced in 1960. And I thought about this and recognized how important he was in changing the lives of so many, you know, unresponsive victims. So I was really fortunate and proud to receive this award and provide this lecture on behalf of that award. When I was looking into the foundation, the Laerdal Foundation, I recognized this vision. As I viewed the Laerdal Foundation website, I was struck by the vision. No one should die or be disabled unnecessarily during birth or from sudden illness, trauma, or medical errors. This resonates with me as most of my nursing career was built on prevention. So how can we prevent complications or progression of illness? As I move through this talk, I hope the vision statement is able to provide an image of how we can all do better in helping save lives and improving patient care. So the objectives for my talk are in 3 sections: how to reduce in-hospital patient decompensation, looking at early sepsis recognition and resuscitation, and then ending with the value of a multidisciplinary team approach to resuscitation. So when we think about avoiding running on empty, it's really, the definition there is that we're exhausted of resources. So what steps do we take in our own lives to avoid running on empty? When our cell phone notifies us that the battery's running low, or the gas tank is low, or toys with batteries are running low, we have some sort of notification and we actually act on it. But what do we do for our patients in the healthcare systems? So here in medicine, decompensation is the functional deterioration of a structure or a system that has been previously working with the help of compensation. So let's look at this a little bit further. In hospital cardiac arrest, the realities of that are that approximately 292,000 arrests occur annually in the United States, and survival is considerably low. Those cardiac arrests that actually occur in hospital on wards is really challenging in the fact that there are limited resources. So the clinician to patient ratio is low in these units, and oftentimes the cardiac arrest is actually preceded by clinical signs of deterioration. So I'm wondering, and we should all wonder, is there something that we could do to prevent such challenges and difficulty in resuscitating patients after we actually see clinical signs of deterioration? So when we look at survival after cardiac arrest, these numbers are from 2000 to 2017, and they're based on data from the Get With the Guidelines Resuscitation Registry. The dotted lines represent the 95% confidence interval. Shockable rhythm includes ventricular fibrillation and pulseless ventricular tachycardia, and non-shockable rhythm includes asystole and pulseless electrical activity. So there's an estimated, again, more than 290,000 cardiac arrests each year. And there's really limited evidence to support decision-making. So it's important that we have increased awareness in cardiac arrests and clinical deterioration to optimize clinical care, and new research may help to improve outcomes. So efforts to prevent in-hospital cardiac arrests require both a system for identifying deteriorating patients and an appropriate interventional response, such as a rapid response team. And we'll talk about that a little bit more as we get into the multidisciplinary teams as well. This particular article I found fascinating, from 1987, and it was looking at medical patients at high risk for catastrophic deterioration. So this has been going on for 30 years. So 30 years ago, Dr. Sachs and Charleston saw that medical patients were at high risk for deterioration. And interestingly, they found that one of the significant signs was acute dyspnea, and that was a significant predictor of arrest. So most patients, based on this particular article and in the previous article, that there was some degree of advanced warning. So what is it about the advanced warning that we're not necessarily paying attention, or we think it's something else? But it is a most important predictor of an arrest was the patient's clinical course in the hospital. So being aware of what happened to the patient during their time in the hospital was key in identifying a potential challenging or difficult outcome, such as a cardiac arrest. So how can we identify deteriorating patients? There's new works in the works of machine learning and artificial intelligence. Some of us have algorithms that we follow to identify deteriorating patients and scores that are built into our electronic medical records. And others use a framework that has puts patients on a classification, whether on high risk, low risk, medium risk of deterioration. But there should be something that kind of highlights the fact that one particular patient may be at higher risk of deteriorating compared to another. so that the clinical team, the nurses and the physicians potentially will keep a closer eye on this particular patient. And then obviously there's a lot of factors that go into creating such a score, or risk factors that may go into that score. So machine learning and artificial intelligence is good, but it also requires collaboration with the clinician. So it's not just that we can use machine learning and AI, which is extremely helpful. And as this technology improves over time, I think we're all going to be well adjusted to it. But clinician input is also key in making assessments. So we can't always just use what the computer's telling us. We can use that in addition to what clinicians see and how they can improve care for patients. So this is an example of a product that was looking at using mobile monitoring solutions in preventing cardiac arrest, published in 2017. So in this schematic, one can see how a wireless sensor can gather data for early detection of events and deterioration and send it to a central repository and automate an early warning to a mobile device, which is also multi-purpose. It can also be used for point-of-care ultrasound. So in the early detection, it looks at respiratory events, cardiac events, post-operative bleeding, and sepsis. And again, it's just a small sensor that's used on the wrist or the finger. In this particular study published in 2016, they were looking at machine learning methods and conventional regression for predicting clinical deterioration on the wards. And in this study, there is a large multi-center database with 5 hospitals from November 2008 through January 2013. There are close to 270 patients and patient admissions, 16,000, close to 16,500 adverse events, where there were 424 cardiac arrests, 2,800 deaths on the ward, and 1,300 ICU transfers that occurred during this study period. And they were looking at the patient population or those on the medical surgical wards, and the primary outcome was looking at cardiac arrest, again, ward to ICU transfer, and death on the ward without attempt at resuscitation. Basically, what I'm going to show you here is that the predictor variables, and interestingly, the most common predictor, again, was respiratory rate, similar to what they were showing 30 years ago, that dyspnea really makes a difference in the patient's clinical deterioration. So recognizing respiratory rate, heart rate, and age as the 3 primary components in predicting clinical deterioration is interesting. So 30 years ago, they predicted using respiratory rate as an elevated respiratory rate or dyspnea was associated with clinical decline. And again, here in 2016, they're showing the same thing. So it's something to think about, something that seems so benign as respiratory rate, which some of us pay a lot of attention to while others may not. It's interesting that that is actually a potential indicator for clinical decline. In this particular study published in New England Journal in 2020, this was actually looking at automated identification of adults at risk for in-hospital clinical deterioration. So they used a validated model that uses information from the electronic health record to identify patients at high risk for clinical deterioration. And this permits automated real-time risk score calculation. Investigators developed an intervention program that involved nurses monitoring patient records. And once patients were identified as high risk, those results were communicated to the rapid response team. And some of the outcomes, the secondary outcomes, included ICU admission, length of stay in the hospital, alive in the hospital 30 days. But the primary outcome was mortality 30 days after an alert. And what they found is, in this unadjusted analysis, the intervention cohort versus the comparison cohort, that the advanced active alert monitor program in the intervention group showed that they had lower incidence of ICU admissions, shorter length of stay in survivors, and lower mortality within 30 days. So this intervention, this advanced intervention where it was not only the alert, but it also used some clinical expertise where the nurses were reviewing the charts and then notifying the rapid response team. Really did seem to make a difference in outcomes in this particular group. But again, this would need to be, repeated in another setting. And the research study was also funded by the Gordon and Betty Moore Foundation, as well as others. There are also some clinical assessment tools for sepsis that we can use or have used. One is the Quick SOFA. That score needs some prospective evaluation in ward patients. So the Quick Sequential Organ Failure Assessment is 2 or more SOFA points near the onset of infection, and that's associated with a greater risk of death or prolonged intensive care unit stay. The Muse score actually is the modified early warning system, and that score, the score is greater than or equal to 5 or statistically linked to increased likelihood of death or admission to an intensive care unit. And then some institutions have created their own homegrown automated alerts in the electronic medical record. So I think there are some tools that are available for sepsis clinical assessment as far as deterioration. It's just that some need a little bit more evaluation, especially in patients that are on general medical surgical floors. So we talked about, the use of rapid response teams, and early on we mentioned that rapid response teams could potentially make a difference. And then in the one study, the Escobar study, it appeared that notifying the rapid response team to assess patients really seemed to make a difference. And in this chart here, it's just basically showing us the difference between the traditional code team and the rapid response team. So many hospitals have initiated sepsis response teams as well, and suspected or confirmed sepsis, having an intensivist at the bedside, being able to administer fluids and antibiotics, transfer to the ICU. There also have been reports of cardiac arrest teams to expedite transfer to the cath lab and initiate targeted hypothermia if indicated. So in the traditional code team, it's primarily looking at cardiac arrest and respiratory arrest or airway obstruction. But the rapid response team can actually respond to specific criteria, the patient's hypotensive, or if they have an elevated heart rate, or again, respiratory distress. And they focus a lot of attention on patients with sepsis, pulmonary edema, arrhythmias, and heart failure. And again, the team makeup may vary depending on the resource availability, but the in-hospital mortality is certainly considerably lower when the rapid response team responds versus the cardiac arrest team when they respond. It's obviously we're trying to catch patients earlier in their clinical course and hopefully intervene before deterioration occurs. So what's the importance of early sepsis recognition and resuscitation? In 2004 was the first guidelines. We're currently working with the 2016 guidelines. The 2020 guidelines should be coming out soon. They were kind of delayed due to COVID, but I believe they should be out within the next few months. But you can see there's been a lot of progression in the guidelines as far as the volume of material and references, indicating that there's been considerable research done over the years related to sepsis over the past 14, 15 years. And the findings actually over time really inform and have been modifying, assisting us in modifying the recommendations. So as we know, in 2012, the Surviving Sepsis Campaign guidelines recognize the fact that there should be some methodology in our guidelines related to improvement. So one of the recommendations was that the hospitals and hospital systems should have a performance improvement for sepsis program in place, including sepsis screening for acutely ill and high-risk patients, and that was a best practice alert. So that was first presented in the 2012 guidelines. And part of the reason is that early patient identification is key. The majority of our patients present to the emergency department, and it's sometimes easier to identify sepsis when they present directly to the emergency department. Sometimes it's a little bit more challenging if the patient is admitted to the ICU for another reason. and subsequently develops sepsis. And similarly, in the medical surgical unit, sometimes it's difficult to identify patients because their signs and symptoms may mimic other disease processes, and plus the resources may not be there to monitor the patients as closely. So the current bundles, we have the 6-hour and 24-hour bundle. Again, the 3 and 6 hour bundle. I'm taking myself back now. In the 3-hour bundle, we have measuring lactate, obtaining blood cultures, administering broad spectrum antibiotics, and crystalloid for hypotension or lactate of 4 or more. And then for the 6-hour bundle, we need to apply vasopressors for hypotension that has not responded to fluid resuscitation to maintain a mean arterial pressure of greater than or equal to 65. And then in the event that hypotension after administration of fluid or lactate of 4 or more, we need to reassess the volume status of these patients and tissue perfusion. And in the US, we have to document these findings, but it's important that we assess the patients and determine whether or not they responded to our initial treatment. And again, if the lactate was initially elevated, we should repeat the lactate. So the 3 and 6 hour bundle were incorporated in the US for the Centers for Medicare and Medicaid as a SEP1 bundle for management of sepsis and septic shock. So in this particular article published in 2014, there were volunteer sites that entered data into the Surviving Sepsis Campaign database using the early bundles, the 6-hour resuscitation bundle. And in this paper with nearly 30,000 patients, we can see that mortality on the wards continued to be higher than those who presented to the emergency department. Also, we find that patients with low compliance, meaning they didn't meet all the targets in the bundle, with a resuscitation bundle had a higher mortality than those in the high compliance group. So this really prompted us to create a new collaborative, so the Surviving Sepsis Campaign Phase 4, where we really focused attention on the general medical surgical floors as a performance improvement program for early detection and treatment of sepsis. And the mantra for this was to screen every patient, every day, every shift. And this applied to nurses outside the emergency department. And the key here was that at that particular time when we first started this initiative, not everyone had an electronic medical record. So there were some nurses that were screening on paper and some nurses that were screening with the computer. But most sites by the end of the collaborative actually did develop some alerts. And some of the sepsis alerts will kind of tell you 2 different things. One may tell you that sepsis is probably present versus those that tell you to look for sepsis. So it depends on how the alert is built, but it could actually present differently in how you assess the patient. So why should nurses screen for sepsis? This whole initiative of sepsis quality improvement on the wards was really focused on nurse screening. And part of the reason is that nurses are in a good position to screen patients, looking at early recognition, which leads to early intervention. Also, it helps when you screen a patient that has sepsis in looking for and trying to prevent progression of organ dysfunction, because we know that with each additional organ failure, the patient's mortality increases. And then again, evaluating and assessing patients, with responding to the treatment, and also to plan for disposition, whether they need a higher level of care or they're ready to be discharged. But overall, our goal really is to decrease delay in sepsis treatment. So in order to decrease clinical deterioration, we need to ensure that patients are receiving the right treatment at the right time. So for every hour delay in antibiotics and other key steps, increase the odds of death by 4%. And this was based on a study that was completed with the New York State hospitals. I believe it was 149 hospitals, following the 3 and the 6 hour bundle. So again, decreasing delayed sepsis treatment is key. In 2018, the Surviving Sepsis Campaign leadership updated the bundle and updated it to the hour 1 bundle. So it's really focusing on quality, timely treatment of the sepsis bundles, and focusing on beginning resuscitation and management immediately, and importance of the nurses in implementing this. There was some controversy between 2018 and 2019, and I think it was just primarily a misunderstanding that the controversy about some people were reading it as 1 hour bundle, meaning they had to implement all these initiatives within 1 hour, but that really was not the case. With this infographic, you can see they're focused on the fact that sepsis is a medical emergency, and the hope is that once sepsis or septic shock is identified, that the 3 and 6 hour bundle will be implemented within the first hour, but not necessarily will everything be completed within the first hour. So what's the value of a multidisciplinary team? We've reached the final portion of this talk. This is our team, very happy. This is what we would hope we would have in our ICU. And basically the benefits of a multidisciplinary care team are to improve patient safety, decrease length of stay and cost. And again, it also helps with job satisfaction. In this particular study, looking at the details of 158 clinical administrative staff and 9 participating hospitals and Get With The Guidelines registry, they saw 4 themes related to resuscitation at the top performing hospitals. It was a team design, team composition and roles, communication and leadership, and training and education. And here you can see the recommendations for resuscitation teams: dedicated teams, clear defined roles, emphasizing respect across the disciplines, and hospitals should implement mock codes. And nurses have a specific role too, mentoring and debriefing and identifying training needs. So education and training is key in these high performing hospitals, using data to evaluate in-hospital cardiac arrest and outcomes, and using nurses in leadership roles and as clinical champions. So nurses have a key role as well. So not only do we want to have multidisciplinary teams, we also want to have cross-departmental teams where the emergency department, critical care units, and medical surgical units work together. So with that, in our summary, we talked a little bit about in-hospital patient decompensation, specifically primarily related to cardiac arrest, early sepsis recognition and resuscitation, and the value of a multidisciplinary team to approach resuscitation. So muchas gracias. Thank you so much for your time. Hi, my name is Christa Schorr. I'm a clinical nurse scientist at Cooper University Hospital in Camden, New Jersey. And it's my pleasure to present to you today Surviving Sepsis in 2071, How, When, and Can We Implement Advancement. So I have no financial disclosures. However, I am a member of the Surviving Sepsis Campaign Steering Committee and serve as the group head for long-term outcomes and goals of care section of the 2020 Surviving Sepsis Campaign guidelines. So the World Health Organization in 2017 recognized sepsis as a global priority. And there were a team of stakeholders who came up with the World Health Organization resolution. So in 2017, sepsis occurred in 48.9 million people, ending with death of 11 million patients. And that was, I mean, that's pretty devastating numbers. But the World Health Organization actually came up with some goals, action items to reduce the global burden of sepsis, such as promoting public awareness and training healthcare workers, about the importance of timely and critical medical emergency management, promoting research to develop innovation means to prevent, diagnose, and treat sepsis, improving some of the classifications, coding information, and monitoring progress toward improving outcomes for patients and survivors. What I'm going to focus on here is looking at the research piece. So if we're looking at action items for developing research and innovation, here it looks like we should include sepsis as a research priority area for funding bodies and commissioned research. However, that's easier said than done. I think, implementing research projects is very challenging. It takes a very long period of time, many investigators, and lots of resources, financial resources. So again, we think it's simple, and putting it on an action item is a good start, but it can be somewhat challenging. So the objectives for this talk are really to look at the past, the present, and the future. So look at the past 30 years from the 1970s forward to the present of 2021, and then how we see sepsis in the future. So interestingly, research has evolved over time, and again, even looking at the guidelines, you can see that there were a significant number of research articles that contributed to the guidelines, but there are also about 30 years of failure in finding effective innovative therapies in sepsis. And it may be partly due to inappropriate animal models or inappropriate selection of patients. When we think about inappropriate animal models, there's a significant difference between humans and murine models, even for clinical signs and symptoms as far as respiratory rate, some lab data as far as platelets, and how humans respond to medical treatment compared to murine models. And similarly with patients, are we selecting the right patients? Are there genetic components that really make a difference in how patients respond to treatment? Is it gender related or age related? Is it possible that some patients develop organ failure and others don't? So again, thinking about, are we actually using the appropriate models when we're trying to assess therapy? So it's quite possible that we have therapies that maybe have failed to show a clinical outcome difference, but perhaps we were using them in the wrong patient population, or maybe selecting the wrong patient population. Another potential reason is that maybe we don't have the best definition of sepsis that we're using in clinical research studies. So in this particular paper, the authors indicated that there's been consensus conferences in 1992, 2002, and 2012, and feels that the sepsis definition is really flawed. And if we don't fix it, we don't fix the definition that's used in research, then we may actually have invalid results. This clinical trial, in 2016, they actually refined the definitions again to sepsis 3. So the third international consensus definitions for sepsis and septic shock, also known as sepsis 3, were published in JAMA in 2016. As you can see here, they included the 1991 and 2001 consensus terminology, where we had severe sepsis and sepsis-induced hyperperfusion, and then septic shock. So for the 2015 definition, we actually removed severe sepsis, and now that term is sepsis, which is a life-threatening organ dysfunction caused by a dysregulated host response to infection. And septic shock is a subset of that group in which underlying circulatory, cellular, metabolic abnormalities are profound enough to substantially increase mortality. So there have been some subtle differences. The interesting thing about the 2015 definition and criteria, they were able to use large databases and retrospectively look at how with sepsis and who had septic shock and what clinical indicators or variables were met, whereas those in the 1991 and 2001 consensus conference really didn't have that robust information. So information from the Surviving Sepsis Campaign database also contributed to these definitions, as well as other large databases as well. So just to think about research, I mean, there's a significant amount of time, money, and energy, and millions of scientists and sponsors that have put, their heart and soul into sepsis research. And unfortunately, we really haven't had any magic bullets to treat sepsis over the years. We still work very hard as clinical scientists to bring studies to the forefront and implement those studies in hopes that we'll find a treatment that'll cure sepsis. But I think part of it is that we may need to look at our strategy and our implementation a little bit differently. So before you can have successful implementation, you need to have a strategy that delivers a successful product. Strategy always comes before implementation. So now we're going to talk a little bit about strategy and why has the failure occurred. Part of it may be due to the lack in precision of sepsis definitions, the heterogeneous nature of the clinical diagnosis. Unfortunately, we don't have that specific test that will tell us a patient has sepsis, so we don't have accurate diagnostic methodologies or biomarkers to really direct clinical design. Ideally, it would be great if we had a test, kind of similar to how we diagnose acute MI. We have a test, and then we have an intervention. But unfortunately, for sepsis, it's so difficult even to make the diagnosis at times that we really have a challenge in designing a clinical trial because we don't have a test to say this patient has this disease process. So it really is challenging. And some of the diagnostic criteria for sepsis are vague and can be confused with other diagnoses. So when a patient presents to the emergency department with septic shock, it's pretty clear that they have septic shock. But for other patients where the signs of sepsis are subtle and they haven't had that clinical change or decompensation, but they need to be observed because they actually may decompensate, you may have multiple diagnoses for this patient until the clinical team can really hone in on all the tests and lab results to determine what the proper diagnosis is. And we may actually go through several steps where we fail and then we learn, and then we fail and we learn, and eventually, hopefully we have success. But we've been failing and learning for a number of years now. And it would be nice if we had something that we could use and to help patients with sepsis for sure. So what's new and what represents promise? So maybe biomarkers, maybe biomarkers are going to be something that'll be some sort of test that we use, and it's beyond procalcitonin. So how do we deal with heterogeneity? We can use predictive enrichment using patient characteristics to select a study population in which drug or intervention effect is more likely to be detected than in unselected population. We also have prognostic enrichment strategies where we select patients who are more likely to respond to an intervention or drug based on biologic or physiologic mechanism. So these enrichment strategies are effective when selecting patients for treatment in trials, such as septic shock. And theranostics are measuring a biomarker to predict what will better match a particular therapy. So again, having some sort of test and then matching a therapy specific to that test and that particular patient. In this study here by Dr. Wang, this is a study that was a secondary analysis of a previously published paper in 288 subjects in 18 institutions. And they looked at prognostic enrichment and assigned each patient, each subject, a baseline probability of mortality using the pediatric biomarker risk model, pediatric sepsis biomarker risk model, or known as PRESERVE. So this predictive enrichment strategy is based on endotypes of pediatric septic shock, which is based on the mRNA expression of 100 genes, and it reflects adaptive immune function as glucocorticoid receptor signaling pathway. So in this particular study, the overview, the hypothesis was that there would be an identified group of children with septic shock who are more likely to benefit from corticosteroids. So each patient was placed in one of two septic shock endotypes based on gene signature and glucocorticoid receptor signaling. And the outcome measure was primarily organ failure and 28-day mortality. And what they found was that the combination of prognostic and predictive strategies based on serum protein and mRNA biomarkers may help identify a group of children who may be more likely to benefit from corticosteroids. So there's more to come in that, and Dr. Wong's group is really doing a lot of work in this particular area. Also interesting is now recognize that the pro-inflammatory response in many patients, that there's an emergence of persistence of anti-inflammatory response that may be predominant and clinically meaningful, and that the enhancement therapy could be beneficial in those patients. Although many people think that this is only coming out in prominence in the past few years, this particular reference is actually from 1996. So the clinical sequelae of the systemic inflammatory response and the compensatory anti-inflammatory response, or CARS, is a mixed antagonist response syndrome. So this has been around for quite some time, but there is new interest in immune enhancement therapy. So this recent resurgence is partly due to the success of immune enhancement therapies in cancer. So in this particular model, you can see here that cancer is not attacked directly. Rather, the immune system's army is released to battle with all its artillery. So that's the concept that we're trying to think, is there something that we could use that we've learned from cancer therapies, and is it possible that we can use some of those mechanisms in patients with sepsis? Also interesting is the gut microbiome's role in the development, maintenance, and outcomes of sepsis. In this model here, published in 2020 by Edelman, I think it's a really nice figure. It shows that recent evidence showed a link between the gut microbiome and sepsis. So prior to sepsis, the microbiome is altered, allowing for bacteria and the pro-inflammatory response, decreasing beneficial microbial products. So there's limited evidence that therapies work, such as probiotics and selective contamination. However, there's some interest that has shown some gut restoration using fecal microbial transplantation. However, that requires additional study and validation. But this may be a promising therapy in the future. So maybe the secret to success is actually patient selection. So maybe it's a combination of finding a treatment, but also selecting the right patient. So here, this model is showing, how we can do stratified medicine, precision medicine, and really to match the patient and their clinical condition, their genomics, their culture, the type of infection and the site of infection to a particular drug. So there's an increased emphasis on personalized medicine, so the right patient at the right time with the right dose. So one size does not fit all. It involves a more complicated approach, which applies potent analytical platforms to assess the genome, transcriptome, proteome of the patient. And together, working with this, the decision is made which drug to actually prescribe, as well as the dose and the timing. So this is a theranostics approach, monitoring biomarker response to treatment. And again, looking at individualized medicine, maybe in our future. So where's the hope for success? We're looking at faster, more reliable diagnoses using machine learning and real-time artificial intelligence. We're hopeful that we'll have biomarkers and diagnostic, predictive, and prognostic mechanisms in place. Improve clinical design to stratify patients, who would benefit from a particular treatment. Maybe not all comers would be candidates for particular therapies. And are there new targeted therapies, including the immune therapies as well as the microbiome? There's also something else. Do we have predictive analytics? So how real-time implementation of predictive analytics using AI models, how that actually influences sepsis care. So when we think about, can we predict who's going to get sepsis and who's not? Well, then what do we do with that information? So if we have tools that predict that this patient is going to develop septic shock, what do we do with that information and how do we prevent the patient from actually getting to that point? But it's important to know that we need to have data that's interpretable, and that clinicians trust, and that it's generalizable and valid. So when we develop these tools and these predictive analytics, we need to make sure that we bring the right team members on to ensure that we're all engaged. So we need to have clinical team members in this process as opposed to the developers just working on what appears to be a good tool. We need to ensure that the clinicians work together with the IT specialists in order to get those tools in place. So in closing, surviving sepsis in 2021 may include a variety of things. We may actually look in our treasure chest at drugs that may have failed or not shown a clinical outcome improvement in the past, but may actually work in certain patient populations. So maybe we need to look at previous medication and device trials and find out if we can match the appropriate patients with the appropriate therapy. We also want to consider the use of biomarkers and artificial intelligence in diagnosis, treatment, and outcomes. And then who knows, maybe we're going to have a microchip implanted as a health tool. Maybe we're going to have this small microchip inserted in our wrist or our neck that's going to be monitoring our vital signs at all times and giving us an alert that we need to contact a provider that we are potentially becoming ill. So with that, I'll close. And thank you so much again for your time. Have a good day. Enjoy the conference.
Thank you. My name is Sayona John, and I'm going to be talking about advances in the management of intracerebral hemorrhage. Intracerebral hemorrhage results from direct bleeding into the brain and accounts for 10 to 15% of all strokes. The problem with the disease is that it carries a disproportionately high risk of death and long-term disability. Unfortunately, intracerebral hemorrhage remains without an approved acute treatment of any proven benefit. And this has led to a variability in care, ranging from aggressive treatment to essentially saying there's nothing that we can do because it's an intracerebral hemorrhage and we need to transition the patient to comfort. The American Heart Association and the American Stroke Association has developed guidelines for the management of intracerebral hemorrhage. Hypertension is the #1 cause for intracerebral hemorrhage. It increases the risk of hemorrhage by more than twofold, especially in patients younger than the age of 55 who have stopped antihypertensive treatments. And what's happening here is that small penetrating arteries are more susceptible to the effect of high blood pressure, leading to intimal hyperplasia and hyalinosis within the vessel wall, which predisposes to focal necrosis and thus to hemorrhage. As a result, the commonly affected structures are basal ganglia and thalamus predominantly, lobar regions in 1/3 of the cases, and brainstem and cerebellum in 17% of patients. And here are scans that show exactly the locations for hypertensive hemorrhages. And the image C, which is a lobar hemorrhage, is often mistaken to be a non-hypertensive hemorrhage. Just to remember that 1/3 of cases, the hemorrhage can be lobar. The secondary risk factors to intracerebral hemorrhage are vascular malformations like AVM, dural AV fistulas, cavernous angiomas, and aneurysms. And this is what most of us are concerned about when we see a patient with an intracerebral hemorrhage. The other factors that can lead to hemorrhages are tumors, vasculitis, drugs of abuse like cocaine and amphetamines, as well as cerebral amyloid angiopathy. CAA is the most common cause of non-traumatic lobar hemorrhage in older adults and is associated with the presence of epsilon-2 and epsilon-4 alleles. Now, what happens when somebody has a hemorrhage? There's the primary brain injury, and then there's the secondary brain injury. The primary brain injury occurs when the tissue is destroyed as a result of blood transecting white matter tracts and destroying neurons. Now, a few days later, what happens is that there is a secondary clinical deterioration, but if you rescan the patient, you will see that the hemorrhage is stable in size. And it's usually in the time frame when edema or swelling is taking place. During that process, there's also clot absorption and breakdown of blood products occurring. And it's all of these chemical factors that are leading to the worsening of the edema and the deterioration in the patient. So for clinical features, these patients usually develop sudden onset of focal neurological dysfunction, and they may be associated severe headache, but headache is not a characteristic feature of intracerebral hemorrhage. Elevated intracranial pressure in the setting of the hemorrhage, it can present with nausea and vomiting, and can lead to rapid progression to coma and to cerebral herniation. Clinical and neuroimaging characteristics are predictive of outcome in intracerebral hemorrhage, and that is why we need to image these patients. We need to understand the size of the hemorrhage, and we need to understand clinically how they are doing, as well as to understand whether they are at risk for secondary deterioration. So the targeted assessment for potential early intervention for patients presenting with intracerebral hemorrhage involves controlling elevated blood pressure, correcting underlying coagulopathy, and determining if this is a patient that is eligible for any sort of surgical intervention, early or late, we don't know. So you also have to anticipate specific individual patient-related needs, such as the risk for early clinical deterioration and hematoma expansion. Determine whether this is somebody who needs some form of intracranial pressure monitoring or other neuromonitoring, and specific treatment aspects that are related to the underlying intracerebral hemorrhage cause. And when I talk about specific treatments, we're talking about making sure that there is some sort of an underlying vascular malformation that would need some sort of a treatment. Now, with hematoma expansion, there's a high rate of neurological deterioration after intracerebral hemorrhage. And this is related to active bleeding that can continue on for hours. However, hematoma expansion does occur early and increases the risk of poor functional outcome and death. And if the patient has underlying coagulopathy, then it increases the frequency and extent of that hematoma expansion. If patients undergo early head CTs, that is within 3 hours of their symptom onset, then usually about a third of patients will have hematoma expansion of greater than 1/3 of the initial hematoma volume. So this is something that we have to accept is probably going to happen and have to monitor for. So then how do you monitor for who's at risk for hematoma expansion? In institutions that do CT angiograms, the CT angiogram spot sign is actually one of the strongest predictors of expansion. However, CT angiograms are not routinely performed. So then how else can we determine if a hematoma is at risk for expansion? So if you look at the plain head CT and see hypodensities or areas of darkness within the hematoma, because the hematoma is usually bright white, and there is a hemorrhage heterogeneity, as in it is not a uniform hemorrhage, and these are known as swirl sign or the blend sign. Those can help you determine if that hemorrhage is at risk for expansion. And this image is showing you the spot sign, as you can see on the CTA in the first, second, and the third. And what this really is contrast extravasation into the area of bleeding, which then puts this patient at risk for continued expansion of hemorrhage. And this image is showing you what the first top images are the swirl sign, and below that is the blend sign. The swirl sign is actually a swirling of the hemorrhage, and the blend sign is where you see a demarcation between the acute hemorrhage and areas that are hypodense. And this is a little bit more clear with regards to the blend sign. You can see essentially different densities to that CT. The CT angiogram additionally can help identify vascular malformations that are associated with intracerebral hemorrhage, and very often patients will get CT angiograms, at least in our institutions. And then you have to determine that who is it that needs a conventional angiography. because the CT angiogram may not necessarily always pick up vascular malformations, especially if there's thick blood. So the indication for getting a conventional angiography is if it's a young patient that is less than 45 years of age, if you have an atypical location for the hemorrhage, or it is a lobar hemorrhage with no underlying history of hypertension, or if you see the presence of subarachnoid hemorrhage or intraventricular hemorrhage. Intraventricular hemorrhage, of course, is blood within the fluid spaces of the brain. So this is a patient that came in with a pure intraventricular hemorrhage and is one of our patients. And as you can see, we got a CT angiogram, and the CT angiogram clearly outlines an aneurysm that is pointing into the hemorrhage, and that was the etiology for this patient's hemorrhage. Now, MRI protocols are also useful. We recognize the fact that you cannot get an MRI as soon as the patient comes in, but if you're unclear about the etiology of the hemorrhage, then an MRI can be helpful as well, because they have protocols or particular sequences of imaging that are specific to blood, in particular the susceptibly weighted imaging, that can accurately help identify what the etiology for the ICH is. It also helps you identify underlying mass lesions. For instance, if it's a tumor or metastatic disease, you may see other tumors that'll help you determine. So in the sequence of imaging that is at the bottom of the screen, the first one clearly is somebody who has cerebral amyloid angiopathy, while the second, third, and fourth are images of somebody who has hypertensive changes. So these are microhemorrhages that you're looking at on the MRI that helps you understand that this is a patient who either has cerebral amyloid angiopathy or has underlying hypertension and has stigmata on the MRI, which help you make the diagnosis. Elevated blood pressure is extremely common in patients with intraseptal hemorrhage. However, the association between the elevated blood pressure and hematoma expansion, while it seems intuitive, the data that we have available is conflicting. So is it the acutely elevated blood pressure that is causing the hematoma to expand, or is the acutely elevated blood pressure as a result of the fact that the brain is trying to perfuse itself? And what is the value in lowering the blood pressure? And not only what is the value, how much should we be lowering it to? So our knowledge about management of elevated blood pressure and the current practices that we used are based on these two papers. The first one being the INTERACT trial, where they enrolled over 2,000 patients with spontaneous intracerebral hemorrhage, and they randomized them to a target systolic level less than 140, or the previous guideline recommended strategy of maintaining the systolic blood pressure less than 180. And they looked at primary outcomes, which was death or a major disability, defined as a modified Rankin 3 to 6 at 90 days. They also looked at the rate of serious adverse events and compared it between the two groups. And what they found is that early intensive lowering of blood pressure did not result in a significant reduction in the rate of primary outcome of death or major disability. They did do an ordinal analysis of the primary outcome, and there were significantly better functional outcomes amongst patients who were assigned to intensive treatment. So we know it's okay to lower the blood pressure. It doesn't really improve the death or major disability, but over a period of time, patients tended to have better functional outcomes if their blood pressure was lowered. The next article that we base our current guidelines is the ATTACH-2 trial. Again, it was a similar kind of trial where patients who had ICH volumes less than 60, which means that they're not large hemorrhages, and had a GCS or a Glasgow Coma scale greater than 5 that were randomly assigned for a blood pressure target of less than 139 or a target of 140 to 180. And in this particular instance, they had to be on IV nicardipine, and nicardipine being a calcium channel blocker, and it had to be administered within 4.5 hours after symptom onset. Here again, the primary outcome was death or disability. Now, the primary outcome of death or disability was really not different between the two groups. However, there were serious adverse events that were occurring at 72 hours after randomization in slightly more patients with the intensive treated group. And the rate of renal adverse events within 7 days after randomization was significantly higher in the intensive blood pressure management group. And this particular study was stopped early due to futility. And the conclusion was that the treatment of participants with intracerebral hemorrhage to achieve a blood pressure goal of 110 to 130 did not result in a lower rate of death or disability than standard reduction to a target of 140 to 179. So this is the American Heart Association's blood pressure guidelines. So if a patient presents to you with a systolic blood pressure greater than 200 or a mean arterial pressure greater than 150, then you should aggressively lower the blood pressure with IV drips. And lowering of the systolic blood pressure to 140 is safe and can improve functional outcomes. However, it is for patients that similar to those enrolled in the INTERACT-2 trial. And one of the major criticisms of both the trials is the fact that both of these trials enroll patients with relatively smaller hemorrhages. If the systolic blood pressure is greater than 220, then you have to consider aggressive reduction of the blood pressure, again with continuous IV infusion and frequent blood pressure monitoring. Now, recognize that the evidence category for all of these guidelines are still not evidence A. So our practice is to target a systolic blood pressure, lowering it down to about 160. It also all depends on what the patient's presenting blood pressure is. But whatever the option is, and whatever the plan is, the key thing is that blood pressure should be managed immediately, and it should be managed using titratable agents so that you're getting to your target value as quickly as possible. And the mainstay of blood pressure management is IV beta blockers and calcium channel blockers that are continuous infusion and can be titrated easily. The key thing to recognize in patients presenting with intracerebral hemorrhage is that they may have underlying coagulopathy. So any intracerebral hemorrhage patient that is presenting to you, you absolutely need to make sure that they are not on antithrombotic medications, because if they are on antithrombotic medications, then there is the risk for life-threatening hematoma expansion. And once this hemorrhage expands, usually it is very hard to make their outcomes any better than death. So urgent laboratory tests should include a complete blood count, and in particular looking at the platelet count, the INR, and the PTT. And we still have patients who are on warfarin for any number of disease processes, and the INR, if it is greater than or equal to 1.4, they should be corrected to a normal INR. So your options are either fresh frozen plasma or prothrombin complex concentrates and vitamin K. Now, we have more and more shifted to using PCC as the reversal agent, and vitamin K must be given because the effect of vitamin K takes some time, while the effect of either FFP or prothrombin complex concentrate is a little bit more immediate, but they're shorter acting. Within 24 hours, their effect is out of the system. So the most important principle is, however, to normalize the INR as soon as possible, ideally within minutes. Now, I think we all know that FFP contains, because it's blood, it contains all of the factors that are required for the reversal of anticoagulation in patients who are on warfarin. The problem with it is that you need fairly large volumes. And you do run the risk of volume overload and pulmonary edema, as well as for transfusion-related events. And it also needs to be matched and thawed. PCC is derived from FFP and contains all of those factors 2, 9, 7, 10, as well as protein CNS. And several studies have shown that PCCs can correct the INR within minutes. Now, the key thing is that the timing of coagulopathy reversal is what makes the greatest impact. So if what you have is FFP, get it going as quickly as possible. And vitamin K, if you're giving it, it should be anywhere from 5 to 10 milligrams, and it should be administered IV. It restores the intrinsic hepatic carboxylation of clotting factors for prolonged hemostasis. And as I alluded to earlier, it usually takes hours after vitamin K administration to help with the continued reversal of warfarin-associated coagulopathy. Now, the biggest question that comes up is the direct oral anticoagulants that more and more patients are on. Now, there are specific reversal agents that are available. For direct thrombin inhibitor, it is idursulfimab. And for the direct 10A, the reversal is andexanet alpha. Now, I also recognize the fact that not every institution carries idursulfimab or andexanet alpha, and off-label use of PCC at 50 units per kg is something we all carry out. However, we still don't know whether you actually need 50 units per kg of PCC or whether you can use lower doses, and there are people studying this currently. With regards to surgery, most patients with acute intracerebral hemorrhage do not require surgery for the removal of hematoma. The theoretical benefits of surgery include the prevention of brain herniation, improved elevations in intracranial pressure, and also remove blood that may produce cytotoxic secondary brain injury. Now, this is the largest trial, the STITCH 2 trial, where they compared early surgery versus initial conservative management in patients. And what the study found is that early surgery does not increase the rate of death or disability at 6 months and might have a small but clinically relevant survival advantage for patients with spontaneous superficial intracerebral hemorrhage without intraventricular extension. So essentially what it showed is a mortality shift. There was improved outcomes in terms of mortality for patients who underwent surgery, but the primary outcome, which was their modified Rankin scale, did not improve as a result of surgery. So the 2015 American Heart Association guidelines for intracerebral hemorrhage state that for most patients with supratentorial ICH, the usefulness of surgery is not well established. A policy of early hematoma evacuation is not clearly beneficial compared with hematoma evacuation when patients deteriorate. Supratentorial hematoma evacuation in deteriorating patients might be considered as a life-saving measure. So what that means is that you can save somebody's life if they're deteriorating and you do surgery, but it doesn't help improve outcomes with terms of their morbidity. The option is to do a decompressive craniectomy with or without hematoma evacuation, which in itself might reduce mortality for patients with supratentorial intracerebral hemorrhage. But what we mean by decompressive craniectomy is you remove the bone, but you leave the hematoma alone. And these are specific patients that should be considered for that kind of surgery. That is patients who are in coma or have large hemorrhages. And then last and finally, the effectiveness of minimally invasive clot evacuation with stereotactic or endoscopic aspiration with or without thrombolytic usage is uncertain. So that's where minimally invasive surgery is being studied more and more, because the goal of minimally invasive surgery in intracerebral hemorrhage is to reduce the manipulation of healthy brain tissue, decrease procedure time, and achieve rapid removal of the hematoma. And minimally invasive surgery is associated with greater hematoma volume reduction than medical management and can be performed faster and with less damage to the brain. So there are several prospective clinical trials that are ongoing with the use of minimally invasive surgery, and those include the ones that are listed on this slide. And there are the fundamental principle here is to make a small burr hole and to stereotactically get to the clot, to engage the clot, and either to aspirate or to leave a catheter in there so that there is drainage of the blood. We are awaiting the outcome of all of these trials. Some of them are complete, but we do not have all of the answers at this present point in time, but perhaps is the most hopeful at the present time for patients presenting with intracerebral hemorrhage. So the risk factors for poor outcomes in a patient that presents with a hemorrhage is increasing age. If they have decreasing Glasgow coma scale, that means they're deteriorating in front of you. If they have a hematoma expansion, that means the hemorrhage is expanding in front of you. If they have intraventricular hemorrhage, if it is a deep or infratentorial intracerebral hemorrhage location, or preceding oral anticoagulation therapy, and possibly even antiplatelet therapy. So these are the things that you need to keep at the back of your mind, because you can very early on determine who's at risk for deteriorating and what you can potentially do to help that situation. Thank you.
Dr. Weirs, can you look at this EKG from triage?
Oh dear. Okay, yeah. Okay, I don't see a stimmy. Thanks.
You sure?
Okay.
Okay.
All right, well, that was a fun little video that we made, kind of a satire on some of the policies we have. Where I practice in Texas, we have a policy that says you have to show an EKG to a doctor 5 minutes after the patient's arrival in EKG. Sometimes that conflicts with our mission a little bit. But I'm Scott Wieters. I'm here today with you, recording live from Temple, Texas, where I practice as an emergency physician with Baylor Scott and White Hospital, and I have the privilege of serving in academics as the campus dean for our Texas A&M College of Medicine. I know that this has been a tough year for everybody with COVID, and I wish that we could be together, but I totally understand. And so hopefully we've got a lot today that we can talk about and help improve the care for our patients. I am a little bit of an EKG nerd, and I enjoy that. So I've got a talk today called Don't Fall for This. And the subtitle is EKGs in patients that are suffering from syncope that you just can't miss. So let's go ahead and get into the talk today, and I hope that this is going to encourage you guys. I obviously have no conflicts of interest here. I am happy to kind of share anything like that. I'm showing you everything that I've got. You can reach me at my professional email at scottwieters@Baylor Scott and White Health, or please join the conversation. I tweet out at emedcoach. All right, well, let's get started with some cases. Our first case is a 64-year-old, and this patient has syncope, and then they came in after syncope and they woke up and their chest was hurting. They said it was radiating to the abdomen, and the nurse kind of said, hey, I want you to look at this patient. And sure enough, when we went and saw this patient, they looked really, really sick. So the way I want you to look through these EKGs is I want you to spend some time and pause. And I want you to commit to reading this EKG and looking at how things are going for this patient. So once you commit, then we'll go through and look at these. So pause. All right. So let's walk through this EKG. So we've got, a P before every QRS. Rate is sinus, looking at about maybe 80 beats per minute. Sinus rhythm. Axis is doing okay, maybe a little towards the left axis, up in 1, maybe isoelectric in AVF, but up in AVL. Intervals, we got a little bit of a first degree AV block, okay, not a big deal. QRS is okay, QT looking all right, maybe a little LVH out here. And then I think what our eyes are drawn to is this depression in AVL in 1. And the way I look at this is the depression in AVL in 1 is kind of the poker tell sign for patients with ischemia. When I see this, these are reciprocal changes, and we see a little bit out here as well. And I need to go ahead and look through, let's see here, down in my inferior leads, and sure enough, I might have a little bit of some early elevation there, but I'm a little bit not comfortable with this EKG. So what we did is, we looked at an old EKG. So looking at an old one, we're not really seeing a lot of the depression in AVL or 1 that we're appreciating in this EKG. Also, this inferior elevation is starting to pop up. So I'm looking at this and saying, man, this is not a good sign. So we went ahead and got another EKG, which again, I always like to get kind of a second, maybe a third, maybe a fourth EKG and see what's happening. Here we can see some even more pronounced depression. We're seeing this also now exhibited even more so in our lateral leads. And we're also seeing a little bit of our PQRS. Look at this, we got a P wave, it's lengthening out, and then it's kind of got a funny appearance to it. And pretty soon, we drop a beat. That right there is a P wave that's hidden in this T wave. And you can see right here is another P wave coming through. So we're starting to see some heart block here. So this is not looking too good. Now, I will say that we had a really great resident on the case that day who said, let's examine the patient, let's take a look at things. We didn't quite react to like activating the cath lab immediately, because when we did our initial physical exam on this patient, we discovered that the patient, upon looking sick, was very hypertensive. This patient did exhibit, again, some bradycardia as we're seeing intermittently. And then when we did our physical exam, we looked down and the patient actually didn't have a pulse down in the left leg. Reached up into the groin, sure enough, didn't have a pulse in the left groin. So I said, wait a second, something's not right here. And I hope you're thinking what I'm thinking, because chest pain within a pulseless extremity or neurologic features, which this person was also having weakness in the left leg, should make us consider things like aortic dissection. So let's look at this EKG. And I'm not a radiologist, but I mean, you can kind of see this lumen and this false lumen coming back and forth here in this dissection, which goes all the way up into his root. Yeah, and it comes up through the arch, and it comes down and it goes into the leg. You can see this thing travel down into the leg here if you watch this come through. Yeah. So this is a unfortunate case of an aortic dissection. So I have to give credit to our team that day. We were able to get the CAT scan done quickly. The resident recognized this even before the radiologist read it. And by the time they got the report back formally from our radiology team, we had a vascular surgeon at the bedside. They took this person to the operating suite and made an amazing recovery on a very complicated case. So I guess the point on that case was, if you have a person with chest pain, EKG changes, not everything is going to be a STEMI, not everything is going to be cardiac ischemia, but this guy was having an aortic dissection, was going back into the root, occluding his right coronary artery, causing that inferior injury pattern, causing that heart block, and then, again, getting the patient the right care that they needed. So great case. Okay, our next case is that of a 49-year-old female who's experiencing syncope and profound fatigue. So fatigue is something that, man, it might be just not a big deal, but sometimes it can be really bad. So let's take a look at this EKG. And again, I wanted to challenge you to go ahead and read the EKG and commit to a plan. All right, and after you've committed, we'll come back and let's read this. Okay, so we've got P before QRS, P before QRS. Our T waves are looking kind of funny here and there. I'm not sure about this. I'm looking through, and this is, again, maybe a P wave right here that's hidden. Look, you can see it in lead 2. Let's watch this. P, QRS, T wave, and then another P wave right there. Another P wave, another P wave. So these P waves are marching out. Okay, so we're dropping a beat. So this is probably a second degree type 1 block. I don't see any widening between my PR intervals. If it was widening with each PR interval, that might be a second degree type 2, but this is a first degree. Mobitz type 1. And so we look through our other intervals. PR looks good, QRS, QT, axis is fine. And again, look at this. We get the AVL, okay? Showing our tell sign, depression there. I look down at my inferior leads, and sure enough, I have some ST elevation. I also want to point out that the ST elevation in lead 3 is greater than the ST elevation in lead 2. This is usually the case when you talk about an inferior STEMI. So when you talk about a STEMI, the lead 3 elevation is more so than the lead 2 elevation. Now, if you can contrast that with maybe pericarditis, benign early repolarization, you'll find that the elevation in lead 2 is more than the lead 3. So that's a distinction. Also, looking at our lateral leads and precordial leads, we see some depression here in V2 and V3 and V4. Now, this is a sign where you might be having, in conjunction with our inferior leads, signs of posterior involvement, okay? So not just using the anatomy, that right coronary comes around for our inferior, but it also wraps around into the posterior leads, which is a larger level of myocardial ischemia. So this EKG read right here is an inferior STEMI, okay? And again, in the right clinical setting, this person's having chest pain, they're having fatigue. Yeah, this is a sign of a STEMI. So very interesting EKG here. All right, so you're working through the emergency department, and take a call. So, yes, ma'am, I know this is a really sensitive conversation about your dying father, but I think that right now we're not...
Dr. Reeves, EKG from triage.
So we're very concerned that your father may not make it through this evening, and we need you to come to the hospital quite soon. Yes, ma'am. I'm sorry. Well, you know, you've just got to look at those EKGs, even when you're having those sensitive conversations. All right, that takes us to our next patient, a 72-year-old male. This person has syncope and chest pain, and they're on dialysis. Okay, so dialysis patient. Oh man, tricky cases here. So this person here, we're considering a lot of different things. So, already I'm thinking about maybe this person's got like a pericardial effusion, maybe they've got, tamponade or something like that. Maybe they got hyperkalemia, who knows? So let's take a look at this EKG. I'll ask you to pause and commit. Okay, now that we're back, all right, so we've got PQRS T wave, we've got a sinus rhythm going right here, rate, rhythm. Let's see here, our axis is up in 1, but it's down in AVFs, up in AVL, so we've got maybe a left axis deviation going on. Okay, understandable. Intervals, PQRS looks good, T wave, okay, looks fine. Moving over here, we've got some big T waves going on. We also have a little bit of LVH, so standalone criteria in AVL, more than 11 in women and 13 in men. So we've got a standalone criteria for LVH. That's not commonly recognized. And then again, the last thing I look at is I go ahead and I look through our T waves, and we got these big T waves. And you might be thinking to yourself, man, those big T waves, is that a hyperkalemia? What's going on with this patient? And I'll say one thing is that the patient actually does not have a high potassium, so we're able to get back a quick I-stat potassium, or maybe the lab came back with a potassium level that was normal. So then we're thinking to ourselves, gosh, what's going on with this case? So I want to point towards a resource that I've really enjoyed reading. If you want to get nerdy about EKGs and really get deep into things, somebody might consider following in the free open access medical education movement, or FOMED as we call it, or medical education online, or on Twitter is Dr. Smith's EKG blog. And so you can find this at, I think it's blogspot.ekg.org or something like that. But just search Dr. Smith's EKG blog. And Dr. Smith is a practicing emergency physician and fellow EKG nerd up at the University of Minnesota at Hennepin County. And he's put together a lot of different cool research projects on EKGs and emergency medicine cardiology that I've really found to be profound. If you want to kind of get the Cliff Notes version, you can go to the MD Calc, which I like, and look at the subtle anterior STEMI calculator. Now there's 4 variables that go into this, and the reason I'm bringing this up is that our initial case is actually a STEMI. Okay, so you can go back to MD Calc and take a look at this EKG calculator. The way I like to teach this is the 1, 2, 3, 4 approach. What I'm talking about is step 1 is look at the calculated QTC. Step 2, look at the complete QRS in lead 2. Step 3, look at V3, and you look at the ST elevation, 60 milliseconds past the J point. And step 4 is looking at the R wave in lead 4. So what we're looking at here, at the top I've got an EKG of an actual STEMI. On the bottom we've got an EKG of benign early repolarization. What we're looking at is the STEMI has a longer QTC and benign early repol has a shorter QTC. Traditionally the STEMI has a shorter R wave in QRS in V2, benign early repol larger. And look at this distance in this relationship between this QRS and this T wave. See how small this one is compared to this big T wave? There just is really a size mismatch from the way that the cardiac tissue depolarizes and then repolarizes. It's just really odd. This one has a much more consistent size of QRS depolarization and repolarization of the T wave. Benign early repol has less ST elevation in V3. Okay, and then the other thing is similar to the QRS size. Look at the R wave in V4 compared to this T wave. This is a very small R wave. This is a big R wave. This one almost comes off of the page here in benign early repolarization. So again, the 1, 2, 3, 4 approach. So if we put these into the calculator on MD Calc, we can find out that the top one is a STEMI, the bottom is benign early repolarization. So let's apply this to our initial EKG that we saw. If I blow this up and look carefully, just take what the computer says, QTC of 450, punch it into MD Calc, QRS is 11, 60 milliseconds past the J point, the ST elevation is 3, and look at this little bitty R wave. It's only 6, big old T wave. That's just not consistent with the size. Sure enough, we put this into the calculator, and it's likely an anterior STEMI. Yeah, that's a tough one. Let's look at this EKG here, and we'll apply the same principle, because these have really big T waves. There's some ST elevation. We're looking at this. We're thinking, gosh, what is this? Is this benign early repolarization? Is it a STEMI? What's going on? So take the numbers. QTC off the computer is 390. QRS here is 22. In relationship to that T wave, which is at 10, not a big deal. ST elevation 60 seconds past the J point is 3. And the R wave, I'm giving you a little bit, even some leeway here, but the big R wave, it probably comes up here, but it's off the page in 17. Now, if I plug these numbers into MD-Calc, what I get is 15.6 points, and that's likely benign early repolarization. All right. So, again, looking at the original EKG that we saw, when I plugged those in, again, taking the 1, 2, 3, 4 approach, the QTC, QRS is small compared to that big T wave, ST elevation, it'll lead 3, and this tiny R wave, look how tiny that is in relationship to the T wave. That's likely an anterior stemming. Okay, so consider taking the 1, 2, 3, or 4 approach when you look at EKGs concerning for anterior ischemia versus benign early repolarization.
Yes, I'm really concerned. I mean, this is a pretty critical patient that I think if they get any chance to get the yeah, so I hope they don't die, but we need to get them to the OR quickly.
Yeah, so you're trying to disposition a patient, have an important conversation, and got to stop to look at these EKGs. So let's see about this EKG that just got shoved in your face. All right, so now we're dealing with an 82-year-old patient with dizziness and pre-syncope, sometimes just as deadly as syncope. So we'll take a look at this EKG. Why don't we go ahead and pause, go ahead and commit to this EKG. All right, now that we're back, I'll probably look at the rhythm strip and lead 2 when I look at this. So I have a P, long distance, and I got a QRS happening right there. I got a P wave, another P wave, and funny looking ST segment there, funny looking T wave. I think that's a P wave hidden in here, and a P wave. So sure enough, if I march out these P waves, they're happening right here, just as we would expect. Okay. All right. And then these T waves, I'm sorry, the QRS is happening, you know, pretty regularly as well. But the P's aren't talking to the QRS as well. And that's a long distance. I mean, that's a really long way. Also, if I look at my other intervals, the QRS seems a little bit long. You know, it's got kind of that right bundle branch pattern, that RSR prime kind of looking thing right there. So that's a little bit snaky there. All right. So rate, rhythm, our axis, we're up in 1, we're up in AVL, so reasonable axis there, although this is a big S wave. Okay. And then ST segments, we've got some ST inversion there. That's understandable with the right bundle branch block. Okay. So this right here looks like a complete heart block, okay? So we have a P, QRS, P. These P waves are beating at their own interval, but the T waves are beating at their own interval. Okay, and it's widened. It's a right bundle branch pattern. So this is a 3rd degree heart block, all right? So crazy kind of a case. So no wonder this person's feeling kind of pre-syncopal and probably even syncopal if we don't do anything. All right, next case, 68-year-old patient with syncope, and we might need to activate the STEMI. Let's see what's going on with this case here. So let's pause and commit to this EKG. All right, now that we're back, and I like this, the machine is fairly good at reading an acute MI. Let's see if it is. So we've got a P, QRS, T wave, P, QRS, T wave. All right, so it's sinus rhythm, rate, rhythm, axis. We're up in 1, up in AVF, so it's a regular axis. Intervals, looking okay here. QTC on the computer is 411, so we're okay. And then we look at our ST segments, and I hope that your eyes are drawn to these appearances out here, which, you know, you get a P, QRS, ooh, big T wave right there. That's kind of a funny looking T wave. ST segment has got a little bit of an odd appearance to it. And if you're like me, you get a little bit worried about this. So what is this? So this T wave is a little bit off right now, and it could be a STEMI. The appearance of this, actually, can I get anyone to bite that says this looks like a shark fin? No pun intended with the bite. But shark fin, that right there is a shark fin appearance. And when I hear shark fin appearance and I see this appearance in an EKG, my heart goes to Brugada. So Brugada syndrome. What is Brugada? Well, Brugada is a condition that is a sodium channel blockade that is inherited congenitally. And this is something that people can have, and it might not be identified until later in life. Now this person, look at this, there's a 68-year-old female. So this person actually was just started on another sodium channel blockade medication called amitriptyline for chronic pain. Yeah, so once this happened, this person started to have this Brugada-like syndrome, started getting syncope because you had a sodium channel blockade condition and you had a medication that has a sodium channel blockade as a mechanism of action side effect, and that's the perfect storm. And so crazy case of somebody developing Brugada syndrome in the later points of life. Now in the cardiac EP lab, what they would do is they might give a challenge of some flecainide, another sodium channel blockade agent, to see if this would bring about this more profound, and then note that the patient was susceptible to this. So, maybe removal of this agent, maybe a pacemaker with further management. We'll have to see what happens to this patient. But this is fortunately for the patient, it's not a STEMI, but this is a congenital sodium blockade condition called Brugada syndrome. Really cool EKG here. All right, this next one. Oh man, I've fallen for this before, but this is a tricky case. So this is a 72-year-old patient who was found passed out on the ground by some family members, and their blood glucose initially was 32. And the paramedics gave D10, and the patient's doing a little bit better. Now, after the syncopal spell, they're still fatigued, having a little bit of chest pain, and they're kind of a little bit not coming back to it all the way. They're a little bit groggy still. So let's look at this EKG. Go ahead and pause and ask you to commit. All right, now that we're back after the commitment, we'll take a look here. And I'm really having a hard time picking out these P waves, but I think if I look hard, I think I've got a P wave coming in here. Got another P wave, QRS. Got another P wave, QRS. And I might be having some other P waves in here inside this. It's really hard to see what's going on. Got this funny looking thing. So we've got rate is pretty slow here in the 40s and 50s. Rhythm appears to be sinus. Let's see, axis is up in 1 AP and ABF, but not a high voltage there. Intervals, definitely got a first degree AV block. That's more than 200 milliseconds. QRS is off. T wave is very slurred and far out. Not sure what's going on with this, but this ST segment is out there, and it's got this funny looking wave afterwards, and even a funny looking wave here. This is actually an Osborne J wave that we're seeing. Well, what is an Osborne J wave? So an Osborne J wave is another ST elevation mimic. We see it here, we see it here, it's in our inferior leads, it's all around, it's all over the place, it's diffuse. This is a mimic for a patient with hypothermia. Yeah, so this person had a core temperature in kind of the high 80s, low 90s when they first arrived, and it's something that I forget to look at in our critical patients. Is one of the last vital signs we get to see is a temperature, and we need to be better about seeing those things because, man, I don't do that well. That's something that I commonly miss, and so I want to share this with you so that hopefully we don't miss getting a temperature on our patients because, again, vital signs are vital. We teach this, but sometimes it's hard to live that out. So this is a hypothermic bradycardic patient with Osborne J waves. They're not having an acute cardiac event. They're having a secondary hypothermic event because their blood sugar was low and they were passed out for a prolonged period of time. So we got this person warmed up. EKG started to get better. Heart rate started to get better. And it's crazy what will happen when people get warmed up again. Okay, next case here. This is a 35-year-old patient with palpitations who just started a beta blocker. And now they present with syncope. So this person had been having symptoms of a little bit of an anxiety. It was kind of profound when they were getting involved with some social situations and had a little bit of hypertension. And so they got started on a little bit of a beta blocker, which was unreasonable, or not unreasonable, totally fine thing to do. And then now it doesn't have syncope. So what do we do about this? Let's go ahead and take a look at this case. We'll go ahead and pause to commit. Okay, let's go ahead and jump back into this. We'll go ahead and look just like we're looking at these rate rhythm axis. Let's see, P wave's kind of tough to find here. It's pretty short between here. Rate looks like it's a little bit fast, maybe close to about 90 or so. Our axis got a big S wave here, so this looks like maybe even kind of a right axis deviation. We're down in AVL. So a little bit of an axis deviation, kind of an interesting appearance. Let's look at intervals now. So the P wave before the QRS is really short P wave there, maybe just, maybe 20, 30 milliseconds. It's pretty short. T wave inverted here, but the intervals look okay. looking out laterally, we can see that there's some T-wave inversion and things. But the most, I think, different thing about this EKG is the appearance of this QRS segment. And it's really hard to find the T-wave or the P-wave in a lot of these QRSs. And it's really slurred upwards. And if I could maybe get you to think about maybe a delta wave. So a delta would be this triangle that I'm making right here. That would be a delta wave. So I'm coming in here with a little bit of a delta wave. That might be how this looks. So what is this? Shortened PR, delta wave. This is WPW, Wolff-Parkinson-White syndrome. Now, remind us, what is Wolff-Parkinson-White syndrome? Well, it is a congenital defect in the conducting system where the AV node is bypassed and the cardiac conduction tissue can get through, and we can have a accessory pathway for the conduction of a cardiac electrical impulse. And that's why our P wave is so difficult to see. It's almost eaten up by this accessory pattern. And this person got started on a beta blocker, which is a SA node blocker, which then accentuates the conduction of this accessory pathway, and they can get into some chaotic dysrhythmias with WPW. So yeah, kind of a cool case. Again, you stop the beta blocker, we'll see kind of what happens and see if this patient kind of gets better from this case of WPW. Yeah, great EKG. Oh man, what a shift. Okay. Gosh, it's like this day won't end. Oh my gosh, finally some peace and quiet. Yeah.
Look at this EKG.
Oh gosh. Okay.
And this one's from triage.
Oh, okay.
And I think this one has ST inversion.
I'll be right there. Okay. So I know you've probably all had a shift or two where you felt like you just can't get away. You just need some peace and quiet. You get to go to the bathroom for the first time in between patients, and then there's just some more crises that happen. And this is kind of one of those cases. This was a real challenging case for our team. This was a young female who came in with profound syncope, cardiac arrest as an outside cardiac arrest, out of hospital arrest. And the history that we got as EMS was pulling in as this person was 2 weeks postpartum. And so this person came in, and we really had kind of a mega code, if you will. This person went through a lot of different dysrhythmias. And I'll show you kind of once she kind of came out of had a torsades arrest and then VFib, we shocked her out of this, gave some magnesium, and this was the EKG after we got a little bit of more stability in this patient. So we'll walk through this one here. So we got a P before a QRS, but man, sinus rhythm, and look at this T wave. Look how far out that is. That is QT prolongation, significantly out there. Got an axis that has a normal axis. Again, the ST segments are a little bit construed because of this T wave, but I think the thing that our eyes are led to in this EKG, and I hope you can appreciate, is the profound nature of the QT prolongation in this patient. This was calculated out at about 800 milliseconds, which to this day is the longest I've ever seen, and I've talked to a few cardiologists that's the longest they've ever seen too. This is an unfortunate case. This young lady, again, had an out-of-hospital cardiac arrest 2 weeks after delivering. So there were a couple of factors that went into this patient's arrest. After a longer history from extended family, her sister had actually had syncope and had a congenital QT prolongation. This person also had a little bit of hypokalemia, hypomagnesemia throughout the stress of the delivery and things, and then started to develop a little bit of a postpartum cardiomyopathy. So a lot of strikes against this patient that led to her arrest. Fortunately, she had an amazing EMS crew that came out and gave her bystander CPR. She had a great emergency team that day who provided some good resuscitation, and then a great cardiology team that was able to identify these problems, insert a pacemaker, get this person treated for their cardiomyopathy and cardiac rehab, and get through this. So this case taught me so many different things. I think we've all got a few cases that have done that, and this one really rings true for me. You know, our patient did well that day, and one thing that came out was the student that was helping take care of that was interested in emergency medicine, and she was distraught. She'd had a grieving process over the loss of a family member pretty tragically, and she wasn't sure if she had the the strength, the grit, the determination to do the difficult job because of the emotional toll it took on her, and she was reminded of it that day. And so we sat down and we talked. We had coffee afterwards and kind of debriefed together, and you know, kind of shared in that grieving moment and the heaviness of the work that we do. And sure enough, this person has now gone on to be an academic leader, and she's really succeeding and doing really well. And I just point that out, that there's a humanistic side to everything that we do. Each of these cases, each of the things we talk about today, it's not just an EKG or medicine, it's people, it's lives, and also the lives of our team. And so I know that this has been a tough year with COVID, and I hope that your team is strong and that you're encouraging each other and getting through this difficult time. So again, it's just been such a privilege to talk with you today and spend some time. I miss you, and I wish you all well. Buenas tardes.
Good afternoon, and thanks very much again to the organizers for inviting me to speak. For the next 15 minutes, I want to talk about monitoring and controlling respiratory drive for patients on ECMO, principally focusing on VV ECMO. Again, my disclosures, nothing particularly relevant for this talk. When we're using VV ECMO for patients with ARDS, yes, we're preventing death from severe hypoxemia, but probably a large portion of the benefit that we're achieving is in reducing ventilator-induced lung injury. When we look at ARDS patients and think about what are the factors that actually drive mortality and what's modifiable, this lung safe analysis here shows these three parameters that we set on the mechanical ventilator, respiratory rate, PEEP, and peak inspiratory pressure, are related to mortality. And you can see here that above a threshold of about 10 or 12, there's a very linear relationship between driving pressure and mortality. So yes, of course, we want to reduce tidal volume, but as this study shows us here, 6 mils per kilogram tidal volume may still not be safe enough in those patients with the smallest baby lung, the most consolidated and atelectatic dependent regions, i.e. exactly the people that we put on ECMO. And so that's where the concept of driving pressure comes in addition to controlling tidal volume. Marcelo Amato's analysis here showing, again, a fairly linear relationship between mortality and driving pressure above a certain threshold. And the idea with ECMO is that can we drive that down? Martin Erner's observational analysis here showed that not only is driving pressure important on day one, it continues to be important on every day of mechanical ventilation, particularly in those with a PF ratio below 150. Now, controlling driving pressure is easy to do in the early stages of ARDS when patients are very severe. We've just placed them on VV ECMO, and they're often fully sedated and paralyzed at this point, and we generate very small tidal volumes and very low driving pressures. Remind you that there are multiple studies now showing that there's a definite association between the amount of the intensity of mechanical ventilation used with a conventional ventilator while patients are on ECMO and their outcomes. From this H1N1 analysis that Tai Pham led in France to an individual patient data meta-analysis of multiple observational studies here. These observational studies showing the same thing, essentially, that driving pressure on the ventilator is an important outcome driver in patients on VV ECMO. Now, that's relatively easy to measure when the patient's sedated and paralyzed, but it becomes more complicated on day 3 or 4 or 5 when you start saying, well, let's take off the neuromuscular blockade and start to lighten the sedation and have the patient breathing spontaneously. In fact, spontaneous efforts are hidden from the usual ventilator parameters that we measure. And a spontaneous breathing pressure patient can indeed have a plateau pressure that's significantly higher than their peak inspiratory pressure, as pointed out in this nice case analysis here. Now, a few words on spontaneous breathing generally in ARDS. There are a number of factors to consider here, and while many people have this idea that spontaneous breathing has got to be good, there are some downsides to consider. First, it may increase the hydrostatic pressures that pull fluid into the pulmonary interstitium, and it may drive this vicious cycle of patient self-inflicted lung injury for exactly the reason that I was outlining before, that the driving pressure that the lung is receiving is much higher than just the ventilatory pressure. It's the sum of both the applied positive pressure from the ventilator plus the negative pressure that's generated by the patient. You can definitely cause ventilation-induced lung injury in animal models. And to complicate matters further, sometimes it can be driven even without a large tidal volume because of the phenomenon of Pendeluft, as just outlined by Takeshi Yoshida and colleagues here, where even a normal-sized tidal volume goes to all in one part of the lung first, and then all of it goes to another part of the lung, effectively doubling its effective driving pressure. Animal models, again, Takeshi Yoshida and colleagues here have shown that in mild lung injury and spontaneous breathing, the lungs were protected. But in spontaneous breathing with severe injury, the lungs were much worse. So there's a matrix between the lung and the diaphragm and spontaneous breathing that makes things more complicated, and it's nicely outlined in this perspective piece about trying to protect both the lung and the diaphragm. So when we're talking about spontaneous breathing, there are a number of questions that come up. When to allow, how much to allow, and should we always try to target normal effort levels? And obviously that implies measuring normal effort levels. Generally, you can think about pros and cons for spontaneous breathing. We feel like we're actually making progress. The patient is moving hopefully towards getting better. We might prevent diaphragm atrophy. We might have improved hemodynamics because of less positive pressure and less sedation and its associated adverse effects. And again, you feel like you're progressing the patient towards liberation. But there are downsides because of potential direct overdistension injury, Pendeluft injury, as I described, increased lung perfusion, dysynchrony and double triggering, and expiratory muscle activation leading to decreased end expiratory lung volume. And these things, maybe the cons may be magnified when the ARDS is more severe, when there's a smaller baby lung, when you have higher drive and more injurious settings. So how to measure effort? Well, there are a number of different ways here that are more or less invasive. Esophageal manometry is becoming increasingly commonly used, and many ventilators have an easy plug and play attachment to that. And that allows one to directly measure the esophageal pressure swings, and we use that as a surrogate for the transpulmonary pressures, the pleural pressures, to calculate transpulmonary pressure and measure muscular effort in that. Another simple way that one of our fellows, Irene Tellius, has nicely validated recently is a simple P.1 maneuver, which is a closed airway and the pressure that's generated in the first tenth of a second. Most modern ventilators will measure this either automatically or on a request. And Irene has shown very nicely that these actually are accurate to gold standard kind of measurements, and you can generate with different thresholds effectively rule in or rule out very high or very low efforts according to levels of P.1, sort of below 0.5. It's very likely that they're making very little efforts, and above 6 or 7, they're very likely having significantly high efforts. Another measure that we complement P.1 with pretty routinely in our unit is just a simple end expiratory occlusion maneuver. Most ventilators allow you to do this. Sometimes it's called a negative inspiratory force measurement, or just an expiratory hold. You don't tell the patient it's coming, and you just measure the occlusion pressure, which is the total negative pressure generated to the PEEP. So if it went from plus 10 to minus 20, that would be an occlusion pressure of 30 centimeters of water. And we've shown that this nicely correlates with measured transesophageal pressure swings, and you can use this as a screening tool for large efforts. You could also use modes like proportional assist ventilation, where you can actually see what the ventilator is doing, its calculated work of breathing, and back calculate the amount of work that the patient is doing. So all these are methods that we can use to measure how much effort. The next question then says, well, okay, I've measured it and it's high. What can I do about it? Well, here we can increase inspiratory assist. That'll decrease effort in many cases, but that may not be feasible because that may lead to just increases in tidal volume. Sometimes increasing PEEP can help, even on ECMO, and by increasing end respiratory lung volume, that can decrease respiratory drive and can decrease efforts. Occasionally, we have to resort to full neuromuscular blockade, but here, obviously, we're trading under assist for over assist, over assist for under assist there. One technique that we use occasionally, but it still requires deep sedation, is partial neuromuscular blockade, where they're still able to generate some muscular effort, but not too much. And then, of course, for the purpose of this talk, we can use our sweep gas settings on extracorporeal life support to try to modulate efforts. We've known for decades that at least in lambs with healthy lungs, you can completely shut down spontaneous ventilation by removing CO2 in a linear fashion. That we'd use CO2 removal as a form of lung protection, again, is not new. It was proposed in the 1980s. For practical purposes, we have data to show that at least in patients on full ECMO, sort of in the recovery phase of their illness, we can often modulate respiratory drive and efforts using sweep. In this study by Christian Karjanidis, you can see that as the sweep gas went down, the electrical activity of the diaphragm went up. And similarly, as sweep gas goes down, tidal volume goes up, and then you put the sweep gas back on again, and tidal volume goes back down, and EDI goes back down. So we can use ECMO to modulate respiratory drive. But I will say in our experience, especially earlier on in the course of illness, not every patient will be sweep gas responsive, and some will have high drive no matter what their CO2 is. Presumably their respiratory drive is being driven by inflammatory markers and other factors in their lung. This animal study shows that, again, we can modulate the transpulmonary pressure that's achieved depending on the ECMO settings, from as low as 6 to 35, depending on how much CO2 is being removed. And this was using a CardioHelp with a bicaval cannula, 2 liters per minute blood flow, so not even full ECMO to do this. But really, the changes that we saw in tidal volume and esophageal pressure weren't borne out until more than 80% of the CO production was being removed. So suggesting, again, this is not something that can be done with low flow ECOR, but for patients on full VV ECMO, something to consider. So I've tried to show you that, and this is opinion-based medicine, not evidence-based medicine. Then in patients whose X-rays look like this and they're fairly early in their course, then yes, we set 6 mils per kilogram or lower. In fact, we often just put driving pressures of 10, and then once they're breathing spontaneously in a day or 2 or 3 after that, use sweep gas plus or minus sedation to try and control respiratory efforts and prevent large driving pressures, even if tidal volumes are under control. If driving pressure is associated with outcome in VV ECMO as we think it does, then to me it makes no sense that we would have a patient on pressure support of 10 or pressure control of 10, but making spontaneous efforts that lent their true plateau pressure to be 30. That's why I think we need to control and modulate respiratory effort in this. And if you're not specifically checking for it, you can be completely blind to that in most ventilator settings. They will just record the peak. You won't know how much effort the patient's making. Of course, at some point you need to transition to letting the patient breathe on their own and not getting too fussed about it. And this is somewhat arbitrary, but we often make this transition, a week or two into the illness when patients are clearly in the recovery phase. And this is analogous to most trials of lung protective ventilation, where once patients were on low levels of pressure support and low levels of PEEP, they allowed any tidal volume to take air. So I've tried to tell you that the impact of spontaneous breathing on ARDS depends on the timing and severity of the disease. Measuring patient effort is important and easy to do with multiple different ways to do that. And when you're allowing spontaneous breathing, consider normalizing efforts to protect both the lung and the diaphragm, especially early on in your ECMO run. And with that, I'll stop and be happy to take questions. Thank you very much.
La mañana ya confirmó el doctor Gattinoni que sí va a estar con nosotros mañana en vivo y pues mañana va a ser nuestro último día. Pues muchas gracias y buenas noches a todos.